Hi, Nigel. Good morning.
Good morning.
We're just about to start, Nigel. Would you just like to knock your camera off and your your sound?
Hang on.
No worries.
Richard, you're live.
Thanks so much, ladies and gentlemen and members of the public, panel members. It is great that we are meeting this morning for our Adult Social Care and Health panel. It is the first one since February, and as per our meeting schedule normally, I have an initial notice to read out, and I shall do that now. Due to the coronavirus pandemic, the Council will be holding this meeting electronically in accordance with the relevant regulations. Members of the public may also attend this meeting in an electronic capacity, and there is a link on the Council's website for them to do so. Members of this meeting are asked to keep their microphones and cameras switched off until called to speak, and to switch their microphones and cameras off once they have finished speaking. To indicate a wish to speak, members should request to do so using the members' chat function. At the end of the debate on each item of business, there will be a vote. Members should vote using the meeting chat function by indicating for, against, or abstain. I will declare the result after each vote. That will be confirmed by officers. Officers are in attendance, but will keep their cameras and microphones switched off unless called to speak. Breaks will be incorporated into the meeting as appropriate, and I'm actually thinking something around 11:15, but I'll make sure it's a natural break in the meeting. Thank you, and we'll have a 10-minute break. Disclosures of interest. Do members have any pecuniary or other declarable interests that might be an issue for this meeting? Speak now or forever hold your peace. No, that's fantastic. Thank you very much. I'm now going to ask members if you would like to introduce yourselves. So be prepared to turn your mic and your camera on so members of the public can see who you are, even though you're in the background most of the time. So I'll just invite Nigel. Would you like to say who you are?
Good morning, Richard and everybody else. Nigel Quinton from Handside and Pear Tree Division in Welwyn Garden City, Lib Dem.
Thanks for being with us, Nigel. Thank you. Drida?
Drida Gordon, Councillor for the London Colney and Highfield, Labour.
Okay, thank you, Drida. Karine? Do we have Karine this morning? Whilst Karine's sorting herself out, we'll have Dave. Dave Hewitt.
Thank you, Richard. Dave Hewitt, representing Cheshunt in Foxbury.
Thanks, Dave. And I know you've been unwell. Thank you for joining the meeting, going above and beyond as usual. And we look forward to your contribution. Thank you for joining us. Fiona Hill.
Thank you. Member for Royston Eastern Ermine, Conservative, and Deputy Executive Member for Adult Care and Health.
Good to see you this morning, Fiona.
Thank you.
Tina Howard.
Good morning. I'm Tina Howard, representative of South East Hemel Hempstead. Thank you.
Good morning. Welcome, Tina. Jonathan.
Yeah, Jonathan Kay, Conservative Councillor for Ware South.
That's great. And that's a really good tie, Jonathan, this morning. That's excellent. Michael Muir. Okay, just while we're waiting for Michael, and Karine can come back as well. Nigel Bell, we had the other Nigel earlier.
Yeah, good morning. I'm Nigel Bell. I'm Labour representative in West Watford. Thank you.
There we are. I suppose I ought to introduce myself, didn't I? I'm Richard Roberts. I represent the Kings Langley ward. I'm the chairman of this panel, and I'm the cabinet member for adult social care and its relationship with health. Thank you very much. Andrew Stevenson, are you there?
Yes, Andrew Stevenson, representing Hertford, All Saints, and a Conservative member.
Thanks, Andrew. Ron.
Thank you. Thank you. Ron Tyndall, we can't get the camera to work, but Ron Tyndall representing the Liberal Democrats, Hemel Hempstead, St Paul's. I'm also the opposition portfolio holder for adult care.
Thank you, Ron. And finally, we've got William Whitelow, and just a request is Corrine out there as well.
It's worth mentioning that Karina's put it on the chat, unable to access microphone. Anyway, I'm William Whitelow, I represent Hemel Hempstead Town, and I'm a Conservative.
Okay, thank you, William. And of course, the reason we didn't hear from Michael is right. We haven't got Michael on yet. He was substituting for Fiona Guest. We'll get some clarity of that through the chat in a moment. And Corrine, just message as and when you want to say something or put your thoughts in a message if your microphone's still not working, but you might need to reboot to rejoin the meeting. Just to let those who have spoken, you all come across really clearly. So no need to raise your voices. Your volume seemed very good as well. Clarity in the pictures seemed fine. Thank you. I've had no apologies. I would just like to start by recognising that it's a long time since we met. It was back in February. We have a new director through Chris Badger, who was with us this morning. Chris, would you just like to say hello?
Hi, colleagues. Can you see me? Okay.
There we are. That's good. And just to say, so Ian McBeath has gone to Bradford to be their Director of Adult Social Care and Public Health, and Chris has stepped up to the mark. And there's been some other changes following that as well. So Helen Manerf is now deputy within the department. Jackie Aubrey has taken over the finance lead and will be supporting Helen. And one other, I should say as well, as part of supporting this meeting, the work of Elaine Manzi and the team around democratic support is nothing short of miraculous to get us all functioning through this meeting. So thank you very much to them as well. Tanya Moore recently completed a PhD. She'll be presenting to us later. And just to recognise that she has completed that doctorate and is now Dr. Tanya Moore. So congratulations to her. I would, there we are. Could I move us on to the minutes from February and just ask Chris to cover a couple of points, and then I think Ron wanted to ask something as well. There were two items, significant items that we covered at that time. One was respite care, where we made significant changes, and one was dial-a-ride and community access to transport and some charging changes, which has subsequently come through Cabinet. But just a very quick update, as it is such a long time ago since we made these decisions and where we are currently. Chris?
Yeah, can you hear me okay, colleagues?
Hear you fine.
Yeah, okay. So on dial-a-ride, we're continuing as planned. I think letters to service users are going out this week. On short breaks, clearly the COVID outbreak and various lockdowns meant there was a delay to that process. So we delayed the closures to February. Reviews have been restarted as discussed with both the panel and the scrutiny. So they have been restarted. They'll be going on between now and November. Clearly, we weren't in a position to do reviews in the way we would want during lockdown, and hence the delay to that process. We committed to bring a report back to panel. I'm going to suggest that we bring back something in the November meeting. I think it's November, isn't it? Not October. The November meeting to provide a fuller update. And I think that retains the commitment we made to do a 6-month update at the last panel. Clearly, we've had a freeze in the process, so that would now better fit at the November panel.
Thank you, Chris. Can I just ask Dave if you could knock your camera off? That would be appreciated. Ron, you wanted to bring a comment on the minutes?
Yeah, I think Chris has answered most of my queries, and I'm happy with his responses. The one thing I would add on the respite care is that there was a commitment to totally involve the parents and users in any redesign of the service, and so I trust. I realise we are constrained with the current problems, but within the constraints that we're forced to have, that if that commitment could be undertaken, that would be great. Thank you.
Good point, Ron. Chris.
Chair.
Yes, and agreed, Ron. And also, across a whole range of our services, we're aiming to absolutely keep our commitment and principle to engaging service users in changes that we make and day-to-day services. Clearly, we have to do it in a different way using technology, but actually I've seen quite a lot of strides in how we've done that, for example, through our co-production boards. And actually sometimes using the technology is less disruptive to people's lives than coming into a meeting. So I think there's some real positives to be taken.
Chair.
Thank you, Chris. It should be re-emphasised that the co-production boards were all reorganised about sort of 6 to 8 months ago. And the commitment across ACS to engagement with both carers and the cared for is a number one priority. But thanks for raising that, Ron. Absolutely right to do so. Nigel, would you like to come in?
Yeah, thank you, Chair. Yeah, I was that same sort of point I wanted to make on the respite care, and obviously some residents, certainly in my division, were just a little confused about the dates. Obviously now with the freeze. So I don't know, will a letter go out, or has that been made clear now to most residents about what the timetable now is after what Chris has said?
It's been made clear, Nigel, but we'll happily do further comms if there's still issues. Maybe if you drop me a note around where that confusion is with your constituents, we can get a further note sent out. If that would help.
Okay, thanks. I will. Thank you.
There we are. Are there any further comments on the minutes? Bearing in mind this was back in February. No, that's fine. I'm not going to seek your agreement. We'll take that as agreed, as we have discussed the key issues that I thought were arising from those. Thank you very much. And at some point, I will get back to County Hall, and I guess I will sign them to do the official part. I'd like now to move to invite Alex Ogle. Sorry, Dave, can you hear me? Can you just, could you turn your camera off, please? Thanks very much.
I'm sorry, it's turning itself on.
Okay, well, there we are. That's lovely. I'd like to invite Alex Ogle to now present the performance report. We have a presentation from Alex picking up some of the highlights. But this is a two-part, really. It's recognising some of the performance from last year in its totality, but also the first quarter of this year, which of course has been hugely impacted by the COVID and COVID response. But Alex, if you'd like to take us through your presentation, that would be great. Thank you.
Yeah, no worries. I'll take any questions after, and hopefully I don't go too fast through this, because I did try to trim it down a little bit. But as Richard said, what we're trying to do is do a bit of an overview of performance from 1920 and some of the good news stories, as well as just some of the kind of activity that we've had over that year. And then a bit of a focus on the Q1 performance. It's a bit of an odd time, obviously. So I've just picked out a couple of key measures from the performance report in this presentation, but happy to go through any other points if we wish to. But obviously activity is a bit different at the moment. We're hoping by the end of Q2 we'll have seen some of the effects that the COVID is having on some of our performance measures. But I shall get started, and if there's any questions, I'll come back to them in the end, if that's all right.
Good.
So I'll quickly go through. So hopefully everybody has this presentation and can see it on the screen. Very quickly, what we've done is on this slide is just give a quick overview of what Hertfordshire looks like, population-wise, just very, very high level versus the people we support. So obviously you can see from the left-hand side there that Hertfordshire have a population of 913,000 roughly over 18, and a pretty even split across the county. So about 50% either side in Herts Valleys and East and North. Vast majority of the population is 18 to 64, about 22% age 65 and over, and then a pretty even split again for male and female across the county. That changes quite a bit when we look at who we actually support. So generally, each year we support about 18,000 adults with long or short-term services at any time. Majority of those are in Herts Valleys, about 47%, 39% or 38.5% supported in East and North, and about 14.5% outside the borders of the county. And you can see with the kind of demographics that the switch between 18 to 64, so we support less adults aged 18 to 64, which you'd expect, and about 62% age 65 and over. And the switch, interestingly, as well, as we support more female adults, 61%, than male adults. And actually that goes through a lot of our statistics. Things like safeguarding tend to have more females involved because of who we support. The first slide I really wanted to do, and this is Appendix 2 of the actual performance report as well, was just to look at our national survey results for last year. So we send out the Adult Social Care Survey every year. It goes out to a group of adults that are receiving long-term services from us, and it asks a myriad of questions, but the key ones that we get measured on nationally, I've put up here on this slide. And we sent out about 1,187 surveys last year. We had about 38%, 451 returned, which is a bit lower than the previous year. We had about 40% in 18-19, but the results were, shall we say, vastly improved across a lot of the indicators. So for the adults who said our services help them have control over their daily life, that went up to 84% from 80% in 18-19. Those who said they had as much social contact as they would like went up to 48.4% from 47.3. 77.3 said they felt safe, with about 82.7 saying that our services help them feel safe. And that initial one went up from 68.8%. In fact, the only one that dropped slightly on the key statutory indicators was the ones that say our services help them feel safe, but that was only a slight drop. 68% said they were satisfied with their care and support, and that was up from 59%, so that was a very big leap. And it actually is the best that we performed over 6 years across that survey question. And 75.5% said they found it easy to find information and advice about support, and that was up from 72.5% the previous year. So across 6 of the ASCOF indicators, or the statutory indicators that we have from that survey, we had really good improvement. So I know we mentioned Tanya Moore's coming on later, and she's talking a little bit about connected lives and the potential that actually that connected lives process has had a massive effect on some of these results. To the right of the screen there, you can just see some of the comments we have. And I mean, this is a small amount. There's only a couple of questions where we get additional comments added. But in the green, there's a kind of more positive comments. And in the grey, we've kind of got not necessarily negative, but comments that were just about improving things like more travel options, needing to have more hours of support, and visit times. And the visit times is a regular pattern, and changing of staff is the kind of feedback that normally comes through. And then some of the positive ones were very much about care homes. And interestingly, care homes was one of the areas that vastly improved. So older people services, we split it out a little bit between the two areas just to give a bit of a view. So younger adults, performance dropped a little bit, but it's still very high in comparison. But older adults is where the real area of improvement happened across the survey. And in particular, adults in residential care, which is a smaller cohort we send out to, but that cohort had a vast improvement in their survey results. So a lot of good results there. Okay. The next thing is just to look a bit about our activity. And I've done this before, but it just gives you a bit of a kind of flavour of what we did in the year. So we had about 26,300 new requests for support last year. 23% were for adults aged 18 to 64, about 6,000 requests. And you can see the vast majority, 77%, were for adults aged 65 and over. It's a slight decrease. So normally year on year, that increases and increases, particularly after the CARE Act. We've had more and more people, new requests for support from the authority, but that dropped slightly last year. And that may have something to do with COVID coming in the sort of last couple of months, really, of the last financial year. 59% were signposted, which is the same as it was in 18-19. So the biggest majority of adults coming through are signposted to voluntary services or just given information and advice. 13% were given equipment or an adaptation, and that's up slightly from the previous year, which was about 12%. And 7% received a long-term service, i.e. long-term residential or home care, and that went down slightly from 18-19. So it was about 8% last year. And that's people coming straight through the front door, and then kind of splitting off across those pathways. And as you can see, the majority are given those kind of information advice or short-term services. The next slide talks a little bit about maximising independence. So it's more of a focus on the adults that go through our enabling style care services. So about 2,845 new adults received that short-term service to maximise their independence, slightly less than the year before. But 21% of adults received another short-term service, i.e. equipment or adaptation, or potentially short-term residential as well. About 73% of those adults were discharged or diverted from hospital settings. So it is the biggest contributor to short-term to maximise independence or enabling style services. 82%, so a big majority, required no further support or less support than before when they came out of that service. It is slightly down from 2018-19, but nationally, we tend to be above England, our comparative authorities in the Eastern region on that performance. And we also sent out a local survey around enablement, and 73% of the adults surveyed were satisfied that the support they received as part of their enabling care made them feel more independent. A little bit about hospitals and social care. So, as we know, there's been a lot more activity in hospitals last year. So our discharge team supported about 16,589 referrals from hospital settings last year. This is up 13% from the 14,000 the previous year. Non-elective admissions was the highest year we've ever had in Hertfordshire. So it was 128,126 last year. And you can see that's up from the 118,500 or so in 18-19. So there's a lot more activity last year coming from hospital settings. About 15,000 discharges into social care. So I'll explain a bit. So the 16,000 is us being notified that there is potential that this person will require social care. And then of that number, about 15,000 were actually discharged into social care, either into our enabling style services or residential or back home with home care, for example. And that's up 15% from the previous year. About 70% of adults discharged into social care went through that enabling style pathway, which we talked about on the previous slide. And there's a further reduction to social care delays from hospitals since the start of the year. So about 35% less adults were delayed due to social care in 1920. And that's about 50% from April the previous year. So big reduction in those delays, and a lot of work went on to kind of reduce those delays coming out of hospital. And we'll talk about that in a little bit, because obviously that stopped, monitoring of that has currently stopped under COVID. But we had some really good results on that up until February. The next bit is a bit about the long-term needs of adults being supported. So just to give you a bit of a flavour, normally we have about 28,000 adults that we deal with over 18 at any one time. Now that might be waiting for an assessment or in a long-term service or a short-term service, but generally it's about the 28,000 mark, and that was the average last year. And we talked a bit earlier about there being about 18,000 adults receiving some sort of service from us, and with about an average of about 12,000 receiving a long-term service at any one time. Last year, we supported about 4,587 in residential or nursing settings. That's down a little bit from the 4,774 in 18-19. We supported 2,482 with a direct payment, and the direct payment bit, if we recall from previous sessions, is that kind of real choice and control, adults getting money, their personal budget directly, so they can spend it how they see fit on services. That's down slightly from 1819. We support about 33,535 adults with a learning disability with a long-term service. Again, that down slightly from 1819. And I will say that some of these numbers look like they're dropping off, and there is a bit of effect on the COVID in the last part of the year that might be potentially affecting some of that. And about 66% of adults receiving service for more than 12 months had a review of that service in the year, slightly lower than the previous year. Our younger adults, so we talked a little bit about how many we supported, and we supported about 5,392, so there was more in the year being supported aged 18 to 64 with a long-term service, and we supported about 4,400 out in the community, so the vast majority, with about 992, about 18% in residential settings. 37% of those adults choose to take their services in the form of a direct payment, so a much bigger proportion than our older adults cohort. 6.8% of those adults were in paid employment in the year, so a bit of an improvement from 1819. And 78.7% of our adults are in settled accommodation. And what we mean by that is they're basically not in a residential or nursing setting or sofa surfing at any point. It means they're they're in a setting either in their own home or in supported living. And about 87.1% of our younger adults said our services help them to have control over their daily life, which is an improvement from 1819. And then a bit about older adults. We talked a bit there about direct payments, but older adults, and it's a national picture, about 15% of our older adults chose to take their services in the form of a direct payment, a slight drop from 1819. 69% of older adults have been receiving their services for more than 12 months, which is slightly more than 1819, and that tends to be the pattern for our older adults. There tends to be less people at the moment in the last few years going into long-term services, but those that are there are actually receiving them for a longer period of time. About 73.7% of our older adults said they found it easy to find information about support, so that was an improvement from the previous year. And about 63% of our older adults were satisfied with their care and support, and we talked about it a bit on the first slide, but you can see that's a pretty strong improvement from the 57.5% in the previous year. And we tend to support about 9,000 adults, older adults, and we talked there just a bit about how that's reducing slightly year on year. And again, COVID may have had a kind of effect on that somewhat in the last couple of months of the financial year. 61%, a more closer split than younger adults are in the community, with about 39% supported in residential settings in the year. And then a bit about carers. So we've got, we supported 4,468 carers in 1920 directly with the council. I say that directly because we also support Carers and Hearts to provide help and support to carers. But about 1,700 were given information and advice. 1,300 chose to take a direct payment as a service, and 423 received a direct service. And what I mean by that is they had their own care plan and they received some sort of respite or short-term service to give them a bit of a carer's break. About 972, the majority receiving that type of service, had that through their service users, their cared for persons care plan. I hope that makes sense, but we could come back to that. About 43% of carers supported were aged between 65 and 84, with 11% 85 and over. And the majority of the carers that we support tend to be older, and many of them actually receiving services themselves. 2,482 carers were assessed by adult care services in 1920. So there's a bit of a drop from 1819, and 40% of carers cared for somebody with a physical support needs, so the majority, and then 13% for adults with a learning disability. And we talked a bit about Carers and Hearts there, but they supported about 30,536 carers last year. I'll stop there, Richard, because I don't know if it's best here to talk about those slides. If anybody has any questions first, I don't know what your thoughts are on that.
I think there are a number of councillors have indicated they wish to ask questions. I think Alex, I think we should do quarter one as well.
Okay.
I'm picking up a little bit of feedback. I'm not sure why that is, but anyway, I think let's do quarter one presentation first. I have a note of those who wish to speak, and ask questions. But I think best that we do all the presentation at once. Otherwise, we might carry on too long. So let's crack on.
Okay, so as I stated, I've just picked out a couple of key indicators from quarter one. I'm happy to chat through the report. I can bring the report up in the same way, but it's a bit of a strange time in regards to the performance. There's not been massive changes in activity, bar that of potentially residential or nursing. But I just brought up a couple of indicators that to look at quarter one, and the first one being here on the left, which is the number of adults with a learning disability in paid employment, which we talked through on the slide earlier. And obviously that's in year. So when we measured it earlier, we had a pretty good performance last year of 6.8%. That dropped a little bit into quarter one. So that dropped to about 6.3% of adults in paid employment. And you can see from the chart there, you can see where our targets are, where we are in quarter one. You can see we're 6.8 last year, and our nearest comparator figures that we had, which were for 18-19, unfortunately, because we're a bit delayed, was 5.8. So we tend to do better against our comparative group. Our Eastern region numbers are a little bit higher, but authorities such as Essex perform incredibly well against these kind of indicators. And I've done a bit of a breakdown here for you to have a little bit look at the quarter one performance for our services. So you can see our adult disability service, which generally deals with adults from 26 to 64, performs that a little bit better. So 7.4% of adults with a learning disability in paid employment in Harts Valley, 6.8% in East and North of the county. Apologies, I see that the 2.4 doesn't have a label under it, but that's our 0 to 25 service. And that's a bit of a difficult grouping or cohort to get into paid employment, because a lot of that cohort aged 18 to 25 might be in full-time education, so they've got less of a group to work with in regards to getting paid employment. But you can see that kind of that cohort of learning disability adults 26 and above have a much higher performance for East and North and Harts Valleys.
Yeah.
1.2, which is the next one I was going to look at, was and this is page 4 of the performance report, I should mention, will increase the portion of older people still at home 91 days after leaving hospital with reablement or rehabilitation services. So that is adults leaving hospital over 65 between October and December of 1920. And of those, the proportion that was still at home, so not back in hospital or in a residential setting, or have passed away in that 91-day period, had a bit of an improvement in performance. So at the end of the year, we had a bit of an effect of COVID, obviously. So we had a larger rate of adults who had passed away in the time period. So we achieved about 80.2% for quarter 4 of 1920. That improved to 84.2% for quarter 1. So we've had an improvement, an increase on that. Our target is about 86%, so we're not too far away from that. And we've done a bit of a breakdown there just to give you a kind of flavour of the age band and gender differences across the board. So you can see from 65 to 74, about 80% of male adults tend to be at home after the 91st day, where a larger proportion of female adults in that age group tend to be at home. 75 to 84 tends to be the best performing cohort of adults coming home after rehabilitation services, about 89% male, 86% female. And then it's the 85 and over, particularly the male cohort, 78% tend to be at home after the 91st day, whereas 85% of female adults tend to be at home. So it tends to be the female cohort that that benefits or is still at home, has a more kind of effective outcome from those services, according to the way that indicator is counting the figures. And the other two we kind of picked up was a little bit about the direct payment stuff. So we look at service users with the direct payment. Performance dropped. We actually did quite well at the end of quarter 4 for 1920 on our statutory indicator. We got 28.6, which is the highest performance that we've had for a while. So these are adults with long-term community-based services, so not residential or nursing, who have chosen to take their personal budget provided by the local authority in the form of a direct payment to go out and purchase their services themselves. So we had about 28.6 at the end of last year. That dropped a bit in quarter 1 to 27.3. Our target is 29%. not a massive push. You could see from the chart there for the further breakdown for quarter one, a breakdown across our services. And we talked a little bit there earlier in the activity bit about how younger adults are more likely to take up a direct payment, about 30+%. You can see that in the breakdown, particularly our 0 to 25 service adults, so the adults 18 to 25, 66% of that group choose to take a direct payment, about 35 for adult disability services in East and North, 37 for our adult disability service in Hearts Valleys. And then the older people services, as you can see, less take up, which is again is the kind of national picture, about 14% of adults in East and North and about 70% of adults in Hearts Valleys. I've put in the mental health cohort there, which is about 9%, but we have to work with our mental health colleagues to update those figures towards the end of the year, so that should improve a little bit as the year goes on. And then from a carer's perspective, the proportion of carers who receive a direct payment has improved quite significantly over the last couple of years. Those of us who've been around long enough knew that it was kind of a 60% point, or in the 60s at one point. It just has kept improving over the last couple of years. So in quarter one, we achieved 75.6% of our carers choosing to take a direct payment. And that was an improvement on where we finished for the end of last year, which is about 75.4. So not a massive improvement, but an improvement all the same. Comparator information is a bit up and down because a lot of authorities assume that the only carer service is a direct payment. So in that case, all carers have got 100% direct payment, whereas we include things like carers breaks and carers respite, etc. So that kind of remainder 25% or so are receiving some sort of service, but they've chosen not to take a direct payment. They've got a personal budget and they're getting respite or short-term breaks. Again, you can look at the kind of split across the services, a similar split to the adults. So 0 to 25, 100% of their adults or their carers take direct payments. East and North adult disability services about 83%, more in Hearts Valleys about 96%, and then in the older people services, similar to the adults, slightly less in East and North for older people, about 64% of carers, and for Hearts Valleys about 71%. To be honest, I know that's a bit short, but those are the key ones I was going to focus on. I'm more than happy if everybody's looked at the report to go through other areas if we want to chat through that, but I shall open it up for any questions.
That's really helpful, Alex, and there's some quite striking figures there. The social care survey has thrown up some really interesting numbers there, and thank you for providing some balanced comment as well to go with those. I'm sure Tanya will want to refer to those in her presentation. I thought what was really striking were the discharge from hospitals, where the increase was huge, some 13%, and the improvement since 2018, something like 50% improvement, is enormous. Those are very, very big numbers. And I know we've got Andy Ballamone and Heidi Hall on the call. So if members bring that up at all, then we might want to hear from them. I certainly would like to, and we'll find a way to bring them in, because those are really significant changes, challenges that have been met. So grateful for that. But I'm going to bring people in. Ron, you were the first to indicate that you would like to speak, so please ask your question.
Thanks, Richard. I think first of all, can I express my thanks and particularly for all of the adult care staff for their efforts over the last few months, because it's been a sterling work, and I think a lot of the metrics that we're looking at and the successes are down to them, and I think I think we need to show appreciation for that. Secondly, I think in these strange times, I'm going to be more interested in the differences between quarter one, which are these figures, and then quarter two, because the dividing line is the end of June, and I'm very interested to see how those first 3 months of the year affected us going into the second 3 months. And I think the trends there may be more important to look at than.
I think there's almost, Ron, you're quite right. There's almost a health warning, isn't there, with quarter one, because it's right in the middle of the phase one of the pandemic.
That's right.
So I think it's quite right that we probably don't focus too heavily on that today.
Yeah, my questions are more on how we're looking after certain aspects. Turning to page 25 and looking first at line 4.3, which is the regulated care, social care organisations. I'm just wondering, how we're basically keeping in touch with them and making sure that they've got everything they need. And secondly, a similar question under 5.3, the people who receive direct payments. I realise that the indicators are slightly down, but bear in mind what I said earlier, I'm not so much worried about that as I am about, are we monitoring, are we keeping in touch with these people, particularly the care organisations and the those with direct payments. And with direct payments, where people prefer to run their own lives, are we making sure that they are able to access everything they want to access and ensuring that they're of their well-being in these very interesting times?
There we are. I think that's the nub of the question there towards the end there, Ron. That's great. I just wonder who would like to pick that up. Who would like to come in to answer that? I almost wonder, is that Tanya or would that be Chris?
I'm happy to answer that. Can you hear me, colleagues?
Yeah, fine.
Yeah, so I'll answer both of those, and I know there's a question from Andrew Stevenson about direct payments too, but I'll start off with the keeping in touch with care providers during the pandemic and quality of the services. So a couple of points on that. Obviously, we've been communicating with care providers on a daily basis throughout the COVID period with a dedicated provider hub to give them everything we think that they need in terms of guidance, support, access to PPE, etc. Through the COVID outbreak. As well as that, we've been continuing to provide monitoring of performance, quality of care. Obviously, we've had to take a different approach to that, sometimes doing that remotely and virtually. We have begun some visits again where we've needed to on a risk assess basis, where we think that's necessary to provide that support and to monitor quality. So we've taken, an approach that balances the risk of visiting sites with the need to ensure that the quality of care is to a standard that we would expect. So that's how we've sort of a two-pronged approach to monitoring care quality. On direct payments, going to your question, Ron and Andrews, yeah, clearly this is an area where we want to increase our performance. We agreed a direct payment strategy last year, just before COVID, actually, and we have recruited a direct payments manager who's a social worker by background to really promote direct payments with our teams, support them to have those conversations with individuals around the benefits of direct payments. I think what COVID has helped us do is have a better sense of, for example, with adults with disabilities, the personal assistant market, which is crucial to how people can sort of manage care for themselves and support. Actually, COVID allowed us to get a better sense of what that market was, a more centralised sort of understanding of who those people were, because clearly we had to support those individuals through lockdown and so forth. So I actually think we're in a slightly better position in terms of intelligence around that. Just conscious we've got a spreadsheet on the screen. Might want to take that off on the screen. So yeah, there's an area where we want to improve. We want to get those rates up and get that sorted. Alex, you've got a spreadsheet on the screen. Do you want to just take that down? Thanks. That's the slide I want. Yeah. We're looking to do that. We've shown with carers direct payments that we can move those figures in the right direction. So it's an area of focus for next year.
Chris, if I may, are we actually maintaining contacts with those that are running their own personal budgets to ensure that they're not running into any problems, particularly connected with COVID, accessing the services they need, etc.?
Yes, we wrote to all people in receipt of direct payment. We've been keeping in contact with them throughout the pandemic, Ron, to pick up any issues, and had a lot of specific guidance to those in receipt of a direct payment. For example, those using personal assistance, to give them advice on things like sick pay, quarantine, self-isolation and so forth, which clearly as an employer with an individual they needed to be aware of. So we had almost like a dedicated set of web pages for them as well.
Thanks very much. Thank you, Chair.
And I think I'd like Tanya to pick up on some of this when she does her presentation as well. I mean, it's quite interesting there that the figures for adult disability services are significantly higher than the average. And then we look at the younger people, and that just shows the ambition around independence and sustainable support. And I guess that goes to the heart of Connected Lives and some of what Tanya will want to speak to us about. So I think that can be developed further there. Nigel Bell, and then Nigel Quinton.
Thank you, Chair. Can you hear me?
Yeah.
It was just going back to earlier when one of the pointers was adults who feel less secure after using services. I just wondered if you could comment on that. I just was a bit worried on that when I first read that.
One of the ASCOF indicators from the survey, yeah.
Yeah.
The only one that's gone down.
Yeah. Sorry.
That's all right. I can field some of that, Chris. You can come in if you wish. So yeah. Sorry, I'm trying to keep up to try and switch between slides before we go through. But so it's kind of a two-pronged one. That so from the we're talking about the 70-73%. So say they felt safe, and they're saying our services help them to feel safe has improved. It was a question that as a regional group, we sent out additional comments for a couple of years before last year. We didn't do it last year because we focused on the control over daily life aspect as part of Connected Lives. But a lot of the worries that came back from that tended to be around falls, cold calling, more sort of community worries, not necessarily directly to the services that adult social care provide. And it's a bit of a difficult one because with some of the national surveys, the questions are in some ways somewhat generic, which leaves it open to interpretation sometimes in some of the responses we get. But on a consistent level, the actual comments that we had back were more people worrying about particularly falls, but safety in the community, and from cold callers or being out and having falls on the street because of curbs and so on and so forth, rather than directly comments about the services we're providing directly to them. If that makes sense, I hope that makes sense.
Okay, thanks. Sorry, through you, Chair. Okay, thanks. That's clearer then. So it's not necessarily after they've had a service from adult care as such. It may be outside, as you say. So that's a bit clearer. Thank you.
Yeah.
Okay. Thank you, Nigel. And Nigel Quinton.
Thank you, Chair. I've got a few comments. Just going through the presentation. So on slide 2, it says that we're supporting 14.5% of the people we're supporting are out of county, which seemed quite a high number. I just wondered if anyone would like to comment on that. The response to the survey, and the numbers are really encouraging. I would just like to draw attention to the social contact question. I think this highlights a big problem that we still have, obviously, with society at the moment, the lack of social contact. And I know that officers are well aware of this, but I think it's just worth noting that it's still less than half are actually happy with the amount of social contact they're getting, and I know that should be a priority moving forward, particularly after lockdown when that's probably been made much worse. I had a question on the slide about which reported the increase in discharges. I'm assuming that's because of COVID, but if not, please let us know. The people with learning difficulties in employment, I'm intrigued to know what Essex are doing differently to us. Is it we're comparing apples and oranges, or have they found the secret that we need to find out what it is? On the other thing that I wanted just to highlight was the drop in carers assessments. This is something that I know Carers in Hearts have been concerned about, and I think we covered at a scrutiny meeting last month. But yeah, again, if anyone wants to comment on what we're doing to address that, because it has dropped off quite significantly. And lastly, on the direct payments, I'm just wondering, why is it good to be high on this? I think Ian McBeath was a little bit ambivalent about this measure in previous discussions we've had. To me, it's more about making sure people have got what they need. Surely it's horses for courses, isn't it? It doesn't necessarily. It's not necessarily the best thing that someone has a direct payment.
Probably about ambition for the service user, isn't it? That's what it reflects. I think that's a really good question, actually, Nigel, and we just could have 2 minutes on that. because it links in with what Andrew was saying and the previous question as well.
Yep.
Okay,
Yeah.
Cool.
Do you want me to take those?
Elements there, Chris, if you want to have a go at that.
Yeah, and I'll probably forget one, so if you can just remind me, Nigel, if there's one I've missed. So yeah, on direct payments, I think there's a balance there between we want people to have that personalised approach, and some people want as much control as they can. Others don't. Others don't want to be able to. Others want a lot more of that to be arranged on their behalf, while having choice of control of what support they do receive, but they'd rather that someone else organised it. So I think there's a balance there. I do think we can do better. I'll be clear about that. I think that we can aspire to do better, especially look to encourage that form of service delivery amongst older people to improve that. But you're right. I think you've got to be realistic that that's not going to be 100% aspiration. On the other one that you mentioned was discharges. The discharges going up. On the whole, that data would have been very much really pre-COVID. What we saw is more people going into hospital with likely ongoing care needs that we've needed to support. We've increased the amount of home care we've been able to deliver, which has been helpful to that. I would note the delays in discharges have been really significant, and I know I'd like to just flag the efforts of Heidi and Andy and their teams in doing that.
Just bring Heidi and Andy. Would you just like to show yourselves, just to both panel and public if you're watching. I know you're not shrinking violets. I would publicly like to commend the work that you've done, Heidi up at Lister and Andy down at Watford. There's other work going on at Barnet Chase, for example, and hospitals all around Hertfordshire where we do discharge. And the improvements have been so significant that this performance really just picks it up writ large. And it was really, really important that those teams were that you lead were really on top of this as COVID hit, because it meant that. And I think what this links into the 84% of the 91-day discharge, whereby not only are people being discharged from hospital, but they are continuing to live successfully re-abled after they leave hospital, and that again I think reflects on good discharge practice. But you have failed to reappear, so never mind.
If you just want to turn your cameras on, Andy, if you maybe mention, or Andy or Heidi mention, just talk through the increase in activity.
So I think my camera's on, and hopefully you can see me.
We've got you.
What I would say is that I think I concur with everything Chris has said. I also think so. It's whilst discharge activity has improved, I also think there's a real opportunity there about just trying to manage that dependency on social care as well. I think we've got some good relationships with our community health providers, particularly in my patch, Herts Valleys, with the Central London Community Hospital Trust. And also there's new relationships that have been forged through COVID with Herts Valleys CCG, where actually we can look towards supporting people's needs, I think, a little bit more cooperatively. And be a bit more joined up, so the dependency on social care maybe can balance out a little bit, and people can get access to the rehab and the continuing healthcare support that they really need. And I think there is a new appetite and new relationships that are there to be exploited in a positive way. I think going forward, but I would absolutely concur with Chris that discharge activities has increased. Delays have reduced, albeit they remain a challenge. But I do think there are a number of different opportunities out there where we can maybe improve and make best use of that social care.
And I think one thing I'd add, Richard, is you've seen the non-elective admissions figures rise. So there's been more people going through the hospitals non-electively, i.e. through, for example, through a fall or an unplanned admission. That then obviously is an issue that then potentially needs to be supported through discharges. We've all got to focus on prevention, so that if we can stop people getting admitted to hospital in the first place, then that then reduces the dependency on discharge. And we know that a hospital stay is not something that tends to be good for people's long-term outcomes in terms of overall dependency. There was a point there, Nigel, too, I think about one I've just forgotten as I've just gone through my head. There was another point about
Chris, we had out of county.
Out of county. Yeah. So on out of county, that's driven by two things, Nigel. Sometimes where we've got someone with a particularly specialist need, they need to be supported out of county. So given that support in a specialist residential setting, for example, where we don't have that provision in Hertfordshire, clearly we'd like to minimise those and have that support close to people's homes. That's not always possible, but we are doing some work to look at whether we can actually provide some of that specialist provision locally, and actually is it worth us investing in either providers or our own capacity to deliver that closer to people's original home. But we also have people that we're responsible for because they were so-called ordinarily resident in Hertfordshire, i.e. we retain a responsibility, but may, for example, have decided to go to a care home outside of Hertfordshire to be closer to relatives, for example. We retain a lot of the responsibilities around, for example, funding their care and checking the quality of their care, albeit that provision is closer to, say, for example, sons and daughters out of Hertfordshire. Also, around the borders, Royston and other areas around Essex and so forth, you're going to have provision that feels very local to people, albeit it's crossed a county boundary. But I think, for all intents and purposes, would feel like it's local provision. So that answered that one. Nigel, what were the other ones? Was there other ones that I've missed?
There was a mention about social contact, wasn't there?
Social contact, yeah.
Which, of course, is an aspiration through Connected Lives. But again, Tanya might want to pick up on that. But also was the a lot of initiatives earlier in the year and last year as well around that.
Oh, maybe I don't know, Tanya, are you on?
I can come on. Yeah, it's absolutely.
Do you want to just talk that through? Turn your camera on, thanks.
Oh, sorry, here I am. Hello, everyone. It's absolutely an aspiration of Connected Lives, and I'll talk a little bit more about that when I'm talking through the model of Connected Lives, if that's all right.
Yeah, cool. Lovely, thanks, Tanya.
So just to mention in terms of carers, specifically, we did a carers survey a few months ago, and we're particularly concerned about social isolation for carers. It's absolutely at the top of our agenda.
Who themselves are often relatively elderly themselves, looking at the numbers. Yeah, thank you. There was, I missed the actual, Nigel Quinton, if you want to come back, what was the Essex comparative was one that you were particularly concerned about?
Yeah, there were two other issues. One was the drop in assessments for carers, and the other one was the performance on employment for people with learning difficulties, where Essex are 2.5 times better than we are, which goes against the grain. So what are they doing differently?
Yeah, that's completely unacceptable. So yes, let's pick up on those two, please.
So on the learning disability and employment one, number one, it's clearly what that's measuring is important, because clearly getting individuals into an employment where that's possible opens up a whole load of things around independence, feelings of self-worth, and an economic independence, which is clearly important. So that's something we're really looking to work on, and we're doing a lot of work with our work solutions team to try and look at how we can target the resource we've got there on those people where we like to make a big difference. If I'm honest, I don't think it's technically a very good indicator. So we don't read too much into the comparisons on the data, because there is an apples and pears issue, I think. So I think the principle behind the indicator is a good one. The actual indicator itself isn't one that I think is probably tight enough in terms of measuring like with like. So we always talk to other authorities about what they're doing, but I wouldn't read too much into the comparative data position there. And I'd say that if we were way ahead as well, that's not just because the performance isn't as good as Essex. We're talking to colleagues all the time on that. On carers assessments, we've had that bit of a dip off. That's something we're trying to address. We've bumped up our resource in terms of carers. We've appointed a dedicated advanced practitioner for carers to focus on our practice with carers. Through COVID, we're undertaking an exercise where we've rung up all the carers that we know of, and out of that we're seeing an increase in carers assessment, which will try and address that fall off. we're a bit unique in that we've got that relationship with Carers Enhanced that other areas don't. So other areas, for example, just give every carer a direct payment without signposting to any other support. We think the investment in Carers Enhanced and specialist support is probably a better model combined with direct payments than simply signposting everyone to a direct payment. And often people will be getting support without having undertaken a carers assessment. But I'd be confident that those figures will go up next year, given the work we're doing to try and target activity.
Okay, thank you, Chris. I think we might want to Nigel's point about employment and contributing to voluntary activity. Maybe that's something we want to pick up as part of a paper that comes to panel in the future. And I'd be happy to make that as a recommendation with Nigel that we do that, just so that the panel understands where the effort is going in that area. Thank you. Thanks for that. We're going to have to crack on here a bit, but Andrew, do you feel that your question has been answered?
Just one quick supplementary. It has been very largely answered, and I was very pleased with Chris's comments about the younger cohort showing much higher direct payment percentages. And I wonder if we could possibly keep track of that indicator in the future, because that seems to me a story that you're succeeding with the younger generation of people in becoming more independent, which I think is a great story. But as just the supplementary question is about your strategy for recruitment of personal assistants. I mean, I've had residents who've had difficulty with that and been discouraged from going down the direct payment route just because of that. But I think you did mention you've recruited a manager. But I think recruitment of personal assistants by people on direct payments can be an inhibition. Now, I just wondered what you had to say on that. Thanks.
Yeah, I mean, I think that points to a wider workforce issue, Andrew. I think we need to do some work on that. And again, as I said, we're in a better position around knowing what the current position is around the workforce, but we are working on ways of improving the overall number that we've got out and up there. But I'll maybe get some more detail offline and share that with the committee about what we're doing on that. I have to say, and this is very much a mixed message, it's likely that recruitment for these kind of roles will be easier in the autumn as we see, unfortunately, an inevitable recession on the back of COVID. That may well be a time where we can actually deliver a stronger recruitment in this area, because we know that when people go into roles like this, they do really value them and find them satisfying. And we've worked with our Care Provider Association to really ramp up recruitment activity ready for when we potentially see some difficulties in the job market, which sadly could be an opportunity for us.
It seems like a great opportunity in a way, and also a good opportunity for independence of these people. So anyway, well done for what you're doing. It sounds very encouraging. Thanks.
Thank you, Andrew. Thank you, Chris. That's really helpful. Drida, you'd like to ask a question?
Yes, thank you, Chair. And first of all, I'd like to add my thanks to Chris and the team for all the work that they're doing in these very difficult and challenging times. And I'd also like to thank Chris for the regular updates that he's been giving us, so that we're in the loop with what's going on. So thank you very much for that. Yeah, I mean, some of the things have already been mentioned, but I would like to come back on several points. One is regarding the social contact, which, as Nigel has pointed out, is quite a low figure, or with potential worries. And I guess that during this particular period of lockdown, that figure may well have increased. And I think there's a piece of work to be done there in terms of if people are going to have to remain in some sort of lockdown for a further number of months, that we might want to speak to them and ask them how we can address that, how we can perhaps put things in place to to help them with social contacting, perhaps virtually or whatever, because this is very important for people's mental health and well-being. The other thing, as you know, Chair, I asked you a question at full council, is about employment for adults with learning disabilities. And I think you did promise then that we would be looking at this in more detail further at panel. So I'm glad to have you reiterating that point today. As you'll be aware, I used to teach children with moderate learning difficulties, and albeit anecdotally, I have to say that I'm always worried when I meet up with these young people and how little, or how few of them rather, have had an opportunity of any paid employment from the time that they've left perhaps full-time education. So I very much welcome that, and thank you for putting the spotlight on that. The last point I want to make, excuse me, is regarding safeguarding. And I note from the report that it says it's too early to tell the effects of COVID on the safeguarding issues, but I'd very much like to see a report coming back to panel highlighting what, if any, the numbers are in terms of complaints and safeguarding issues that have been raised during the COVID period, when members of families and friends have not had access to their loved ones in residential care. Thank you.
There we are. Just before Chris comes in, Drita, thank you for your comments there. In terms of contact, we've got Tanya will pick up some of that when she does her presentation. Employment, we've kind of covered that and said what we'll do. And thank you, Nigel, as well as Drita, for bringing that up. And safeguarding, we'll just touch. I know safeguarding inquiries have increased again in recent months, but do we want perhaps a brief update, Chris, on how we're going there?
Yeah, so as you say, Richard, we saw a reduction in safeguarding activity during lockdown. We've seen that bounce back very quickly, and actually I'm quite pleased with that, because I'd rather know about issues than have them sort of suppressed. I think we're going to have to invest in further resource to support the safeguarding service, given the volumes that we're seeing. We've not seen any massive trends or patterns around safeguarding issues being any different yet post-COVID as they were pre-COVID, or lots of issues coming out of COVID. We'll find out more as we begin to ramp up our monitoring visits that I mentioned earlier in response to Ron's questions around provider assurance around quality. We'll see a little bit more. Then we have seen, sadly, increases across the patch in issues around domestic abuse and so forth, which is a national pattern, but with the safeguarding team, and had a session with the Independent Safeguarding Adults Board last couple of weeks, where we got a good, I think it's fair to say, a good sort of commentary from them about our practice and the consistency of our practice improving, albeit on a journey. And I think it would be helpful, I suspect, to schedule in a dedicated session on safeguarding and where we are and the patterns of types of safeguarding issues to schedule something in for panel either in the autumn or the new year.
I think that's a really good idea, Chris. I know that the Chief Executive and the Leader of the Council, myself, yourself, look at the safeguarding figures on a quarterly basis, and it's really important that we do so. But sharing some of that with and our aspirations around safeguarding, what we've done about it, setting up the new teams, and Mark Harvey might want to say something about that in the future. I think it would be good to share with panel. Thank you very much. That's really helpful. Jonathan, would you like to ask your question?
Yes, thank you, Chairman. Can I just thank Alex for an excellent presentation, and also very good graphics as well, which I think makes a big difference. So thank you very much for that. Mine was also relating to social contact, which of course has been referred to by Nigel Quinton and by Drita, because obviously if 48.4% have as much social contact as they would like, then obviously more than half, over 50%, haven't. But I just really wondered what interpretation we meant about social contact. So do we mean family, friends, relatives, volunteers? Do we mean HILS, the Meals on Wheels people who pop in every day and perhaps make a coffee for somebody that they're attending to? Do we mean the supermarket delivery man or the postman? What do we just mean contact? But I'm happy to wait for a reply from Tanya when she gives her Connected Lives presentation.
Okay, so Jonathan, just it's almost the qualitative aspect of the contact as opposed to the quantitative aspect to it. So I think you're right. I think Tanya can pick up that and quite what that means in the context of community in its broadest sense. That's really helpful. Good. William, I think, and then Ron wanted a little comeback as so often. But William, if you'd like to comment or ask a question.
I didn't want to delay the meeting very long, so this is I'll make it very short. It is about the papers that I was reading as an NHS governor, talking about the NHS wanting to look after housing people who needed further care in the community for 6 weeks after discharge from hospital. And I wondered whether this was something which they were trying to get involved in that they haven't been in the past, or whether it really just related to continuing healthcare.
Okay, William, that's really helpful. It's kind of a technical issue, isn't it? But this is something that does exercise minds. But Chris, could you take us through this? Thank you.
So, William, this is building on the discharge guidance that was put in place for the COVID period, which, again, Andy and Heidi and the teams really led on coordinating with NHS colleagues. What this would change in a sense is that the first 6 weeks of support post discharge from hospital would be funded by the NHS, and in the same way that currently enablement care is, but this would be all types of care. We would still be involved in often securing that provision. It would include people that were both like there and on a longer term basis eligible for CHC and those that weren't. The focus there would be that the assessments for ongoing care needs or for CHC eligibility would take place outside of the hospital where possible. And that within that 6 weeks, the assessments around who would therefore pay for such support would take place, but not in a way that would delay that individual leaving the hospital. We're working very collaboratively with NHS colleagues on implementing that. I think overall it's a good thing. We need to work out how that's going to work, and that those arrangements are in place and came with a guidance note about it about 3 days before it was implemented. I'm confident we've got the arrangements in place to work the implications of that out, because they're far-reaching in terms of commissioning, also finance and income team charging, and where our staffing resources deployed. So you're right to pick it up. I'm confident we're doing it collaboratively in Hertfordshire, which is the only way that it will work.
Thank you for your comprehensive answer.
There we are. Thank you, William. And finally, Ron, did you want a comment at the end?
Thank you, Chair. Very quickly, it's about the metrics. It occurred to me there have been 1 or 2 comments about staffing, particularly personal assistants, and other points raised in some of the answers to questions. And it occurred to me that the ACS performance that we've seen today does not carry any mention of staffing levels, difficulty of recruitment, percentages, anything that and staffing and the recruitment of care assistants is probably at the heart of every care package. And so I wondered whether or not either it's dealt with elsewhere, and I can't think for my moment when it is, or whether perhaps there should be some extra metrics added to the performance in future that covers staffing issues.
Okay, that's perfectly valid. Chris?
Yeah, so Ron, what we're going to do is we've got, so there's 2 issues around staffing. There's our internal staffing within the County Council, and just to say that that's held up really well during COVID, and massive thanks to all our teams. Actually, sickness rates are lower, and people have worked really flexibly on that. Our vacancy rates are actually pretty good at the minute, although we need with some areas where we need to work on it. The wider point, I think, is around vacancies and workforce factors in the wider care market. What we're preparing is probably a 6 monthly report for you on the state of the care market, so-called Hearts Care Standard report that looks at the wider pressures in the care market. I can't remember when we've got that scheduled for, but I think something every 6 months on that looks at quality of care, what performance is around CQC ratings, capacity, and a view around the workforce pressures would be a helpful report. And maybe going back to Andrew's point, we could include in that a section on the PA market to address those concerns as well. But I'd propose that we do that every 6 months. We were about to go live with that before COVID, but clearly we had to put that a little bit on a back burner.
Thank you very much, Chris. Thank you, Chair.
Thank you. No worries at all. Guys, it's good to be back. A full blast of scrutiny right across health and social care issues. I would expect nothing less. A good challenge both to Chris, to Alex, the actual indicators that we bring before you and the quality of them, and then what we do with them. That kind of level of transparency is why we become a successful county, and why we end up bringing the kind of care and support that we do, is because you challenge some of those stats. For me, I think we can pick it out the minutes, but particular issues here around LD employment, contact, direct payments, and kind of that ethos. I think we've all in recent years asked similar questions. So we'll perhaps have a pick up on the flavour of that. The staffing issues Chris has just picked up has answered that, but there's 2 or 3 key points there that we'll bring back to panel in the future. Thanks very much. Good. On that basis, we will formally ask to note this report with those recommendations that have been clearly set out. Is that agreed that we can move on now? Just make a note in chat and that'll be fine. That's great. Thank you very much. Thanks, Stephanie. Can I also, for those of you, and it was the opposition leads, for thanking staff, the effort that has been made by our own HC staff, but also carers working for care providers, both domiciliary care and in care homes and in nursing homes. It has been going above and beyond duty. It is commendable. Thank you so much, panel, for mentioning that and for passing that thanks on. And we shall continue to need that support for months and months to come, I am sure, with the worrying news of figures increasing in recent days. Good. We shall now move on. I noticed the time, panel. We took quite some time over that. It's 11:17. Can I suggest that we come back at 11:25 after a very short comfort break? Thank you very much. We'll just have a 7-minute break. Thank you. There we are. How we do? Must be nearly there now. Karine, have you got your mic back yet, or your pic camera? Okay, I now have an indicator we're back live again, so thank you all very much. We will not have a comfort break after every item, so don't get too used to that. I'd now like to introduce Tanya Moore, our Principal Social Worker, to give us a flavour and an overview of Connected Lives and what this ethos, in a sense, offers adult social care. And Tanya, I wonder, just before you launch into your presentation, you could tell us a little bit about yourself and kind of where you've come from to therefore bring what you do to the role of Principal Social Worker in Hertfordshire. Thank you.
Okay, thank you. Hello, everybody. Well, I'm a Hertfordshire girl. I grew up in Hertfordshire, went to school in Hertfordshire, and was supported by Hertfordshire to do my training all those years ago. I started working in Hertfordshire Social Services as it was in 1986 in a residential children's home, and have worked in and out of Hertfordshire ever since then. So along my 30-year plus career, I have worked in London boroughs, in Hertfordshire, in the voluntary sector. I've taught in university for a number of years, so I'm part academic. And I've worked at the Tavistock in London. Some of you may know the Tavistock and Portman NHS Trust, which is well known for its psychodynamic approach to work. And that's something that I think I bring to my role as Principal Social Worker. And as we talk about the Connected Lives model, it's firmly rooted in relationship-based practice. And I think it's my practice experience and my academic interest that informs that, makes it very theoretically grounded, which I think is, it's part of what makes it a model that other local authorities look to and try to emulate in some way. So that's bigged me up in a way that I didn't expect to do right at the start of this. So I'll crack on now and big up our model instead.
Thank you.
I am really proud of our model, and in Hertfordshire and Adult Care Services, we're really proud of our model. So just to let you know what I'm going to talk you through, and I've been asked to keep it quick, so I really will try to, but I want to say now that if anyone's particularly interested in practice and would like to have a chat with me afterwards or at any other time, I'd be so pleased to do that, to tell you more about what happens on the ground in adult care services. So you've taken a strategic look, you've had a look at, from a very high level of what we managed to achieve and where we need to work a lot harder. But I'm going to talk to you for the next 10 or 15 minutes about how we do that and the model that we use to help us provide the service that we want to provide for people. So it's Connected Lives. This is our model. Oh, that was meant to flip down, it didn't. There we are. Connected Lives, it's the model we use here in Hertfordshire. It's entirely based on the Care Act. It follows the requirements of the Care Act almost to the T, but it's the Care Act translated into practice. And it's the model that helps us maintain a really clear focus in everything that we do, which is about helping people to live the lives that they want. And for most of us, that's about being connected to other people. And I wasn't at all surprised, but I was really pleased to hear counsellors talking about the importance of connections with other people. For most of us, it's the most important thing. And whatever that looks like, I was just remembering when Drida was speaking, actually, when I first started in social care, that we would quote John O'Brien. Drida might know John O'Brien, who came from a nursing background, I think, and was heavily involved in supporting young people with learning disabilities. And I think it was him who talked about the pornography of paid relationships, which is a really striking phrase. And it always makes me think about those people we know who only have people who are paid to be in their lives, who don't have those genuine connections. And that's something that I think underpins everything we do in Connected Lives. We're looking for those genuine connections for people. One of the counsellors mentioned, is it the postman? Is it, the milkman? That may be a genuine connection. That may be something that's really important to somebody, and we would work with that if that's right for them. But also it might not be. Who are those people that people have lost contact with? How regularly do people get to speak to their sister, their brother, their mum, their children? We want to pick up on all of that and help people maintain those connections that are important to them. But Connected Lives isn't just about connecting to other people, it's about connection to communities. There's people in communities, and it's connection to networks, and it's connection to employment, very importantly, and connection to volunteering. It's connection to tech, where tech can help us get on with our lives and the way we want to lead them. It's connection to equipment, and where needed, and for a good number of people we support, it's needed, it's connection to services. Our work always starts with a conversation with somebody, and it's very much a conversation, not an assessment. We've moved right away from the tick box idea of I have a question that I'd like you to answer. And the reason for this is we've learned over the years that if we ask specific questions, we get specific answers, and they don't necessarily tell somebody's story. So in taking what we call a strengths-based approach to working with people, which is about hearing about people's lives, hearing about what works for people, hearing about how people have managed up until now, we get to hear a fuller story. And I was just thinking in the break, actually, when I was getting myself a cup of tea, my mind had gone blank for examples, because I'm a bit nervous about talking to you all today, but something just dropped into my mind while I was making my tea that was about a story I heard a couple of weeks ago about a man who he'd experienced a stroke about a year ago, and because of this needed a lot of support in his life to get on with his life. He was finding it very difficult maintaining his role in the family as the husband, as the father, and this was affecting his mental health to no great surprise. And he was getting a lot of support services in there, but it was a Connected Lives conversation that he had with one of our practitioners, where he said, just, by the by, he said, one of the things I really miss is having a really good wet shave in the morning. That was always a part of what I did in the morning before I went out to work. It told me the day was starting. It kind of sparked me into life. And that wasn't a very difficult thing for us to set up for him, actually. So he now starts every morning or Monday to Friday, he starts the morning with a wet shave. And I'm not pretending that that's been, immediately transformational, but it's certainly been the beginning of him beginning to maintain or beginning to regain that routine that was always so important to him, and him feeling in control of his days. Day starts with a wet shave, and then he can start thinking about what comes next. So that comes from conversation, not assessment. We wouldn't necessarily have got that by asking specific questions. So all the work that we do is it's us working to make sure the person has as much control over their lives as possible. And because of that, we work to, you can see one of our orange bubbles here has got connect and prevent, connect and enable, connect and support. We work through these 3 stages when we're working with people. And the first stage is connect and prevent. It's how can we prevent people from needing any more support than they really do need. And if we get to the realization they're going to need a bit of support from us, we'll move on to connect and enable. And this is thinking about a little bit of support that might be appropriate for somebody, or some cash if that's going to help somebody buy the thing, buy the equipment, have the experience that's going to put them back in control of their lives. But for a good number of people we meet, they're going to need long-term support. But even there, we're constantly thinking that how, even while you're receiving this long-term support, how can you stay as much in control of what's happening to you as possible? And that's where our focus on direct payments come from. Absolutely doesn't work for everybody, but for those people for whom it does work, it really is a good way of people making the decisions that matter to them. So I've talked a little bit about what it means to be strengths focused, and recognising that people have managed up until now, and let's reflect on those stories about how people have got to here, and think about how all of those strengths and those resiliences can be used to keep people carrying forward with their lives. And also being risk positive, recognising that we can't eradicate all risk from somebody's life. Life is about risk. That's all of us took a risk in getting up this morning, working the kettle, crossing the road if we went out this morning. So what we don't want is any care and support that we offer to restrict people and disable people. It really should make lives better. I'm going to move on to the principles that we work to. These are our practice principles. And these underpin everything we do, and we present these to staff. We've got them all presented in a nice leaflet, and we often talk about them because we say that every conversation we have, every supervision session we have with or practitioners have with their managers can be related back to these practice principles. And if they don't fit to these principles, then we're steering off course. So we find these really helpful way of keeping us focused. So I'm going to kind of whiz through them. The first one is about independence and citizenship, because we believe that with the right support, everyone can achieve some kind of independence in their lives, and we want people to maximise their own potential for control over their lives. The second one is every contact strengths-based and risk-positive. All of our practice is about emphasising people's self-determination and focusing on what they can do, not, as traditionally happens in social care services, on what people can't do. We really do have conversations about how can you make that work, and with a little bit of help would this work. So it's about people staying in control. The third one, considering alternatives to traditional care services. You know, we work creatively with people. We try to work creatively with people to think about other ways of helping them get on with their lives other than a traditional service. So a day service may be entirely appropriate and helpful for somebody. But also over the years, we've met many people who have gone to a day service to make friends, for example, to feel less socially isolated. And, you know, some years on, are still going to the day centre and still feeling socially isolated. So it's trying to get to, you know, other ways of making this happen. And there's so much work has been done. There's so many opportunities out there. But we want to look at the non-traditional opportunities. So, you know, how can we help people set things up for themselves or connect into what's already going on? Safeguarding, we mentioned safeguarding this morning. It's one of our most important tasks. It's fundamental to everything we do. Our position on safeguarding is that it's everyone's responsibility. Everybody who has a connection with adult care services, we see safeguarding as being part of what they do. Having a clear understanding of the legal framework, we call it legal literacy in social care. It's the Care Act, it's the Mental Capacity Act, it's the Mental Health Act. These inform all of our practice, and our case notes have to show the processes that we work through. You know, we have to have defensible and accountable practice. What have I got here? Timely and defensible decision making and recording. I just want to mention actually, well-being is a part of the Care Act. I want to mention the well-being principle. So we've got a duty under the Care Act to improve people's well-being, and this isn't necessarily by providing resources for everybody. It might be by signposting, it might be by putting out messages about what's available. It's often going to be about helping people think through what it is that they need. So that's part of our duties under the Care Act, and that's fundamental to the work that we do. Which brings me on to number 6, timely and defensible decision making and recording. This is about evidencing the robust decision making that we do. It's clear recording, it's proportionate recording to the complexity of the piece of work that we've been doing or the situation that we've encountered. And it's always written in plain English and always written so the person about whom we're writing can read it and understand it. Value for money. And effectiveness and decision making. So it's wherever possible, we want people to make their own decisions about how to spend money that's being spent on them to its best effect. And often that's going to be about using direct payments. But also our staff are asked to explore other sources of funding, so continuing healthcare or FNC, funded nursing care. I mean, I'd written down an acronym, forgotten it meant, funded nursing care. Working with partners and providers to deliver good outcomes, so we don't just commission and go, we stick around with services. Once we've commissioned a service, we stay there to achieve the very best we can for somebody. I had a lovely story just recently about a man who had moved into a residential home where his wife was already living, and we worked with the home to enable them to shift things around so that they could live together again just by having 2 rooms next door to each other, and they had one room as a bedroom and the room next door was used as their living room. They had to go out into the hallway to get into their living room, but they still managed to make it work. And it's just kind of thinking about how can we, somebody is now dependent on a long-term service, but how can we make it as right as possible for them? And then support for our staff being a really important principle for us, because this is really difficult work, it's complex work, and it's skilled work, and it creates emotional challenges as well as all the practical challenges that you'd expect. So we take leadership very seriously in the organisation, and good supervision, good professional practice supervision for our staff. And what we think is that these principles offer a clear framework for everyone to work to. And as I said, we refer to them regularly. So what we've been doing over the last year is extending Connected Lives principles and practice across Hertfordshire via our commissioning teams and our in-house provider services and our externally commissioned providers, including Hearts Partnership Foundation Trust. So to do this, we have been working with Hertfordshire Care Providers Association to develop an outcomes-focused framework. And what we really want is to encourage more evidence outcomes-based care planning across the services that we commission in Hertfordshire. And that's just the lovely diagram that our commissioners in consultation with HCPA have created, that it's outcomes focused. It's a whole new way of commissioning, not to time on task, but to what's the outcome, what's the difference, an outcome being the difference on the person's life. And as part of this, all local provider services are being asked to get to grips with our principles, the Connected Lives principles and our strategy, and to decide how they're going to evidence this as part of their outcomes framework. And when we put out tender documents, we ask colleagues across Hertfordshire to demonstrate Connected Lives thinking and to work to develop Connected Lives understanding across their own staff teams. And within Hertfordshire Adult Care Services, we have really focused on learning and development, practice development in Hertfordshire. Our practice development team won an award. I've written down the name of the award here. It was the Skills for Care Most Effective Approach to Continual Professional Development for the Regulated Workforce in Social Care Settings. And I'm really proud of them for achieving this. And the reason that I think that they got it is because every bit of learning and development material that's offered is tied into the Connected Lives framework and to the theories that underpin this. So it's all about relationship-based practice, it's all about connections, it's all about understanding the legal framework that works to that, understanding the different approaches that we can use to help people make those connections they need in their lives. And we've got we've invested in connected leadership, which is a systemic approach to leading. I've written here, leading the successful delivery of Connected Lives. So every leader, from board members stretching outwards, every leader in adult care services is taking part in the Connected Leadership programme. So we're all speaking the same language and all understanding the importance of taking time to think about what it is that we're doing and think about the impact that we're having on other people. And we're just at the point now where we're extending this out to all practitioners as well. So it's the same theoretical underpinning, thinking about what's the impact of me, what impact am I having on people when I'm speaking to them, when I'm alongside them. And we've also got, I'm really proud of our teaching partnership. This is the Social Work Teaching Partnership, where we have received funding from the Department of Health to work with University of Hertfordshire, Tavistock and Portman, Hearts Partnership Foundation Trust, and Adult Care Services, fantastically working very closely here with Children's Services to create good learning opportunities for social workers and develop social work practice for all social workers in Hertfordshire, including social work students in Hertfordshire. So what's all this done? I mean, Alex told you a really good story, so I won't spend too long on this, but we have a programme of internal audits, practice audits that we do on a monthly basis in Hertfordshire. For Connected Lives, we wanted to extend that a bit, so we asked somebody to, a guy called Bill Mumford, who was the director of the Winterbourne View programme, worked at the Department of Health and Social Care. So we asked him to take an external view of our written assessments. And what we did, I mean, it's a small piece of auditing, but it was very helpful to us. Connected Lives went live in April 2018. So just before it went live, we picked out 30 assessments of the existing model, the pre-Connected Lives model, and sent them out to Bill and asked him to audit them to the Connected Lives principles. We then in December, so 6 months in, about 6 months in, 7 months in, we sent him another 30 assessments and asked him to audit these new Connected Lives assessments to the principles of Connected Lives, looking for strengths-based practice, looking for the voice of the person, looking for clear outcomes for the person. And as you can see, there was a slight increase in the quality of the assessments, and we were kind of cheered by that. We didn't expect to see that so earlier on. It was very difficult to make the system changes we needed to make on our Axis system, our recording system. So we didn't, and that was quite a distraction to us from practice. So we didn't expect to see such an improvement, and we're very pleased to see this. But it was a year later, we sent him another 30 assessments, and you can see that there was a significant improvement. Some of our assessments he deemed to be outstanding. There was a significant improvement in the number of assessments that were seen to be good. And in fact, they were all seen to be good. There were no adequates or inadequates last December when he had a look at them. So this was really good news for us. And it was shortly after that that the results of the ASCOF, the Adult Social Care Survey, was published. And Alex has already talked you through these. And this felt, really good. We felt vindicated in our Connected Lives model. It felt like all the work that we'd done was really beginning to produce very, very pleasing results. And then COVID happened. And I don't have a great story for you here, really. Then COVID happened, and you can see here, we suspended our practice audits for the 3 most difficult months through the first outbreak of COVID. So we had our internal audits done in February, and then we resumed our audits in June. And you can see from this that there is a drop in the quality of the work that we've been able to turn out. So I'm just looking at this. You can see we've gone from 41% of our assessments in February were seen to be good, and in June 41% of our assessments were still seen to be good, but in terms of inadequate we had just lost sight of my...
You went from 3 to 14.
Yeah. 3 to 14, thank you.
Yeah.
Yes, thank you. We had a drop, we had a significant, that's it. I'll tell you what it is, I can't see because I've got a little picture at the bottom, I can't see my little model at the bottom here. So we had a significant drop in the standard of our practice, which is really difficult news for us. It's really difficult to see. This is no surprise at all. Obviously, we weren't able to get out and see people through the throes of lockdown. We have been having to do assessments on the phone. We've been learning to do assessments on screen. It's been a very difficult time for us. So we have a plan to reinvigorate practice. And we've just, over the last few weeks, we've been able to start getting out and do face-to-face assessments again. And we think that this is going to be reflected in the audits. We think probably from September, October, we should start to see, in terms of our internal audits, we should start to see a rise in the standard of practice again. It's been very difficult to happen online. But we've got some plans here. We're learning from practice during the pandemic and how we need to adapt to the future. So whilst it's been very difficult, there's been some really good things that have happened. One of the good things, actually, in terms of connecting people to what's going on in the community, some of our community services have gone online to really good effect for people who have access to computers and someone around who can help them to use them. So, for example, does anyone know Electric Umbrella, local music group? They're running regular workshops online, and they're fantastic. If anyone gets the chance to do them, then do. We have we support an inclusive arts festival that was running just this weekend, the Enrich Arts Festival for people with disabilities, people with learning disabilities. And it all happened online this weekend. So whilst, last year you had to get out to Watford to take part in the workshops, this year it all happened online. I took part in a couple of the workshops and watched a couple of the performances, and they really were fantastic. Now, I'm aware of the limitations to that. You need to have access to the internet. You need to have somebody to help you to make those connections if need be. But we have discovered there's another way of connecting with people, and we're certainly going to be learning from that and exploiting that.
I'm sorry to cut across you. Your enthusiasm is infectious, but we've probably gone quite a bit over your 15 minutes. I'll tell you what I'll do. I'll give you 1 minute just to wrap up, and then because people will come in with questions and it'll allow you to enthuse some more. But let's just draw this to a close. Thank you.
All right. Apologies. Okay, so we're importantly, I think for you to know, we're launching the Connected Lives Carers assessment. We haven't had a Connected Lives Carers assessment up to now. We've talked a little bit today about the work that we need to do for carers. That's definitely part of this. We have developed some Connected Lives e-learning programs. We're going to be launching those over the next few weeks. We have been doing some additional work with senior managers and advanced practitioners to help them find the language to communicate the vision and engage with staff and, really help staff to understand how we can work online as well as face-to-face, because this is now going to be the new way of working. I'll perhaps leave it there. I mean, it's learning from what's been happening over the last few months and thinking how that's going to shape practice going forward. Thank you. Sorry to have gone on.
Not at all, Tanya, thank you so much. That's really, really helpful because it brings the practical examples that you've given, also, flavour and colour, the kind of strategic thrust of it all. So thank you very much, really helpful. Ron, would you like to come in with your comment? And then we've got Nigel has also indicated.
First of all, can I thank you, Tanya, for your presentation? And it was fascinating and really, as Richard said, inspiring. What I'd like to do is similar to what I did earlier with the performance figures, is not concentrate on any particular percentages, but look to them to point the way for the underlying features. Now, you mentioned the fact that performance dropped off during the COVID, and perhaps you could identify the main factors where that happened, and whether or not that your understanding of that is guiding you towards preparing a plan. So if and when we get a second wave or a second peak or whatever happens over the next few months, then you are better prepared for events than you were first time round, which of course nobody was prepared for the first time round. But it's basically the learning cycle you've gone through, and then and part of that, if you could pick up the only indicator on page 42 that is downward, which I think is probably COVID related, but it's basically preparing for the future, really.
So we never practiced online. I mean, the big difference and the reason for the drop in the quality of our practice is that we had to stop going out to see people. Our whole model is based on the relationships that we form with people, and suddenly we weren't able to sit in a room with them and have that relational conversation with them. And we had to learn to do it by phone and where possible by screen. So better by screen, but that didn't work for everybody that we support. So if I think about when we're doing, I'm getting feedback. Is there anything I can
Ron, stick your mic on mute, mate. Thank you.
Right.
Sorry, Ron.
That's okay. Don't worry.
So when I think about, for example, I think about doing a capacity assessment for somebody, and we talk about relational autonomy being that when I come out and see somebody, they behave differently because I'm in the room. So as a practitioner, I try to work with that. I try to work with that dynamic and help people think things through clearly and bring out the best in them. So if I'm looking for capacity, do they have capacity to make a decision that they need to make? I'm knowing that I'm having an impact on whether or not they can show that capacity. If I'm speaking to somebody over the phone, I don't have the opportunity to do that. And even more difficult, if they can't come to the phone and I'm just having to ask other people how they behave, what they're doing, how they're responding, I'm depending entirely on what other people are telling me about somebody. It's no wonder that practice dipped. So what we very quickly had to do was learn how to work on screen. And we pulled together information. We got the advanced practitioners together, sharing tips, sharing ideas. There was very little written. There's actually a lot more written out there now. The psychotherapists mainly have published a great deal over the last few weeks and months about how to connect with people online, how to maintain that relational practice. So there's a bigger base of information out there now for us to draw on, but actually we were creating our own stuff anyway. And I think within about 3 weeks, we'd got some quite detailed guidance out based on our own experience that we were able to send out to all practitioners in Hertfordshire to say, some basic things about how to use a screen, how to look at a screen, what kind of background to have on, what things to look out for. When we're doing an assessment for somebody, having a conversation with somebody, where they're sitting tells us a great deal about them. It's not just what people say. How they connect, how they relate to other people in the room tells us a great deal about what's going on in their home, particularly when we're thinking about safeguarding. So it's learning to use the screen to tell us that stuff in a way that it isn't necessarily intuitive.
Thank you for being so transparent with us, Tanya, and letting us know the challenges that COVID has brought in terms of practice. That's really helpful. Thank you. Ron, thank you for your question. Nigel, you had a comment as well.
Yes, it was really just to say thank you for such a wonderful presentation, but also to comment based on what you just said actually as well on the you highlighted the problems that COVID has brought, but I think you were being a little bit unfair to yourselves on the performance there, because I noticed on that comparison you've lost your outstanding cohort, but your goods have stayed the same, your adequates have actually gone up and your inadequates have gone down. So the extremes have narrowed, if you like, and I think during an exceptionally difficult time like this, I think that's really commendable. Well done. That was all.
We'd had, I suppose, under Connected Lives, we'd had a steady ascension, and it was really disappointing to.
I appreciate that, but I also appreciate that mindset of wanting to improve all the time, and I think that's great.
There we go. Thank you, Nigel. That's appreciated. Andrew, did you want to come in with what county councillors can do to support?
Yes, well, first of all, I agree. I mean, I think it's quite an inspirational presentation, and you've clearly put a lot of thought into it, Tanya. And I think improving connectivity is one of the key issues that does need to be addressed, particularly for people with learning disability, but all sorts of disability. And I just wondered, to give an example, in my division, I chair an arts hub, and I'm involved in all sorts of different groups in my division. And by serendipity, I come into contact with residents, with these issues, but it's very random. And I just wondered if your connectivity model could somehow find, in the right sort of a way, a role where, us as county councillors, with all these sort of very often myriad groups in our divisions that we know, how could we play a constructive role in that and in this philosophy looking to the future?
I love that question. I really like that. So one of the things I didn't get a chance to say is that we're about to launch Your Connected Life. So up until now, we've been an inward-facing model. It's been to help us in our practice thinking. But actually, we are about to take it out. We've got a leaflet to take out to say, to people who live in Hertfordshire.
Yeah.
What about your connected life? We know it's good for your well-being, and is there something we can be doing to support you? So I wonder whether it's coming in that way. I wonder whether we could.
Yeah, I mean, for example, I'd be happy for our gallery manager to have a stack of those sort of leaflets. Mind you, we can't reopen the physical gallery, so we're developing a virtual gallery at the moment. So, but all these things can morph into virtual contacts where they have in the past been physical contacts, and the need. I mean, some of the connectivity I've found has actually increased with Facebook groups and things like that. People exchanging in all sorts of ways that I wouldn't have had visibility of in the past. So it's really just an open question, but I think I'm sure there's no easy answer, but I think it's a very exciting direction of travel, basically. Yeah.
Thank you, Andrew. I'm taking it as an invitation.
Absolutely. No, do take it as an invitation. Very welcome. And
very good, very
happy
good.
to introduce you to our gallery manager.
It's not supposed to be a matching service. This is supposed to be...
Okay.
Lives,
very good. We're connecting already then.
I think allied to your point, Andrew, yeah. I think it's worth reflecting that each councillor has a £10,000 locality budget. Yeah. And just how the Connected Lives programme could influence that in terms of getting organisations to come forward with requests to councillors which would support the Connected Lives principles. And I'm sure that happens already, but it might be just a slightly more proactive approach there. Thank you. That would be.
Well, I'd be welcome to earmark. I'd be very happy to agree here and now that I could earmark some money for that in my division. I think that would be a very welcome move. I mean, I have supported over the years groups like an entrepreneurs group, Arts Hug, all sorts of groups. And I think linking that in could be very helpful because people could find volunteering roles, for example, where they could be very well supported by groups that are initially directed at other activities like wildlife preservation or arts, things like that. But if you've got a supportive group of volunteers, they can very easily accommodate one or two people with some form of disability and make them part of the group. And I think that it could be a very interesting opportunity mutually.
Yeah, absolutely. The other way around, because those people with disabilities may just have so much to offer for everyone else.
Oh, they do. Absolutely. No, you're so right. I mean, it's a whole new landscape.
You can do this over a cup of coffee down at the flipping gallery.
All right. Sorry.
Thank you.
Yeah.
No, that's great. I think I've seen, and you probably have as well in the chat, an all-round welcoming enthusiasm for the work that's being done, and that it is still rolling out, and that is having and going to have an influence right across partner organisations in Hertfordshire. And the ASCOF results really do suggest that it's making a difference in how we support people with their independence, with their self-worth, with their well-being. To give them the lives that they should lead and not ones that we think they should lead. So Tanya, go forth and keep selling the gospel because it's obviously starting to work. Thank you so much. That's really, really excellent. Good. I'm really not. I've seen everybody supporting this. I'm not going to seek an agreement to note the report. I'm going to take it as read. Thank you very much. Our next agenda item is the latest, in a sense, the latest because we've had a number through to the special cabinet panel, but our latest response, the first one coming to this panel of the response to COVID. And if I could invite Chris to present this report, which is in reality a synthesis of the last 6 months, but also very much looking forward and preparing for what may come. And as we've already alluded to, and the government's already spotted, infection rates are up. So quite an unnerving time. Chris, if you could lead us into the report, that would be great. If we say sort of a 10 to 15 minutes presentation, and then questions, I'm sure we'll tease out more. Thank you.
Yeah, thank you, Richard. Can you hear me okay? Yeah, okay, brilliant. I'll keep it relatively brief on the basis there'll be a number of questions, and I'll assume you've all read the report. As you say, synthesis of what's happened over the last 6 months. I mean, I think the first thing to say is clearly COVID-19 had a profound and often tragic impact on service users of adult social care, as we've laid out, both in terms of care home mortality, also people in receipt, we think, of home care, although that's more difficult to evidence what the cause of that was, and sadly with individuals with learning disability succumbing to the virus. I think it's first of all put on record our sympathies with those that have lost loved ones. We do know that as a virus it is particularly cruel at targeting those with existing preconditions, or those that are elderly and therefore have got slightly weaker immune systems. So talk there about a number of things that we've done to try and support residential and nursing homes as the outbreak took hold, and very much welcome the multi-agency approach we took there with the colleagues from the NHS, our learning disability nurses, for example, as well as teams within commissioning and operations to support care homes manage those outbreaks and develop where they've their practices as far as infection control is concerned. Clearly, we know in the early stages of the outbreak, the issues around testing and PPE weren't where we wanted them to be in terms of the ability to access those. We're in a much better position now to do that, and that clearly presented some challenges early on. Overall, in terms of care home mortality, we have taken a look at where we are compared to others in the nation, actually, to look at were our outbreaks any worse or better than anyone else. That wherever we are doesn't make up for the fact that we lost an awful lot of residents, and that's a tragedy, just full stop. But it's important to know, was there anything more we could have done? Well, there's always more we can do. But what I would say is that we're at almost exactly the national average for mortality when you measure it per registered care bed. So we're not an outlier in this, unfortunately. We do know nationally that care homes took a particularly hard toll in terms of mortality. I just wanted to then move on to section 5 around the impact on activity. You'll have seen a lot in Alex's slides about the impact that it's had on contacts to the service. We saw a significant reduction, as you can see on the graphs around new contacts. But you'll have seen very much in May and June, we've seen almost a V-shaped recovery, as it were, of activity coming back on pretty quickly. And I think that's good to see. We want to see that, and we want to then get hold of that. That will present some operational challenges to manage that as we move forward. Just wanted to mention 5.5 in-house services. While we had to shut a number of, for example, day services, partly because a number of service users really didn't feel comfortable coming into those environments, we were able to keep up a much smaller service, but for those that really did need that provision, perhaps because their families or their carers were working in roles that they weren't able to take time off from, so that those that did need that support continued to do so. I'll just whiz through this. So one of the things that we've done all the way through is look at managing this as an emergency incident. So from 6.2 onwards, you can see that really from the end of February, we were treating this as an emergency. Regular meetings, often multiple daily, of the leadership team, again linking in very closely with the NHS and working with our providers, Care Providers Association, to make sure everything that we could do to support care providers was put in place. That included significant financial support, which we'll talk about in the next item, but in terms of PPE, funding for agency costs, and funding on levels pre-COVID for activity to ensure providers didn't suffer any negative consequences around, for example, cash flow, and that financial stability was maintained throughout the pandemic. We've had universally really positive feedback from our providers about the level of that support. Some of that's been recognised nationally, and we consider that to be a priority during our response to ensure that any resources we got from government were quickly directed to our wider care market. Going through then support to the NHS. Clearly, we had an imperative to support our hospitals and secure quality discharges throughout the pandemic to ensure they had the capacity to manage intensive care units and so forth. We did that successfully. Commend the work that our teams did leading those responses on the major acute sites, and that's been valued by our partners. And I think in many ways we've had enhanced and I think improved relationships across all partners as a result of COVID. We did a lot of work with district and borough council colleagues around supporting rough sleepers. That was again very much a multi-agency effort, as well as those at risk of domestic abuse, and I've outlined that. I just wanted to focus on 6.27 for a little while, which is the work of the Voluntary and People Assistance Cell, which had significant leadership from Adult Care Services colleagues. Mentioned a whole load of them in the report, but actually the work that we did to help people that were shielding, Operation Shield, and those that needed support during lockdown, Operation Sustain, is outlined there. Number of numbers there about the number of food parcels delivered. Again, operations that really were stood up from a standing start to deliver that support to people, and probably echoing the point that actually for most people the impact of COVID was the lockdown, not the actual virus itself. And clearly we talked about people lacking in social contact that was mentioned earlier. Again, the cruelty of COVID is that it exposes quite ruthlessly those that perhaps don't have that wider resilience or support, and we clearly had to step in to support those individuals. We've clearly stepped down some of those services as the outbreak has subsided. We've made sure that the infrastructure and the systems are in place, ready to be escalated again when we need to over the winter period. So that support can be reinitiated if shielding, for example, is extended, or different lockdown measures are taken. So we're ready to go again if we need to. So we've got a lot of plans in 7 around section 7 about what we might need to do to step up support. That includes continuing to operate the 2 care homes that we reopened, as well as a range of commissioning plans for services that we may require. And then finally, we've already undertaken a significant amount of work to plan for what our recovery will look like. This will be an ongoing bit of work around whether it be activity around connected lives discussions, or support to carers, or financial impacts. That's all sort of laid out there, and a number of the costs that we've had to take on have been listed, and we will talk a little bit more about the ongoing element of financial support in the next item. So I suggest we take questions around finance under that item. But that's probably all I've got to say, because I'm sure there'll be questions that I can answer.
Chris, that's really helpful. Ooh. Well, there was an echo there. Yeah, I think it's Ron's. Ron, you not only bring yourself, but you bring an echo, which is a delight. Can I just a quick comment there? If you look at the costs at 9.2, a range of internal and external agencies that we have worked with, funded, supported to deliver more during COVID. It's quite sobering just what that bill adds up to. And of course, that bill is ongoing, and we'll cover that further in the next item. Chris, thank you for that. Ron, your question, please.
Yeah, I've got 2 or 3, but I've got quite a few more, but I'll deal with those by email. I won't keep everybody's time.
That's appreciated.
First of all, thank you, Chris, and please pass our thanks to the whole team, right down to because without your efforts, we were facing disaster. So thank you very much for that. A couple of points is the testing in care homes. The ideal was to have weekly tests of staff and monthly tests of residents. Are we actually there now, or are we still have difficulties? That's the first. The second one is the comparison of deaths, and I wondered whether or not it might be better, because of, as is explained in your report, the difficulty of reliable figures, to actually try and do a comparison for Hertfordshire between perhaps average last 5 years and then what's happening in Hertfordshire. So at least we know how many people we've lost, even if we're not quite sure where, you know, and that might be a better indication. I think the ONS use that factor, and that's quite a reliable factor as far as the national figures, and if we could use that something. And then finally, I've just I noticed a couple of days ago in the Health Service Journal some constituents being extremely concerned about the discharge guidance that the government's just come up with. I sent you a copy of it, and and they are rather concerned about whether or not everything is going to be fine this time round, or whether we could get in a situation as we were back in March. I think I'll leave it there, Richard.
Thank you, Ron. Those are all quite beefy questions, and they're the right ones to ask. I would suggest as well. Chris, would you like to tackle those? So first one was testing in care homes. Government announcement was for 1 week for staff, 1 month for residents, and then of course we had the issue with the actual tests themselves. Deaths comparator discharge guidance concern.
Yeah, just to flag on the discharge guidance one, we'll take that one last. I'll maybe ask Heidi and Andy to take that one, just in terms of maybe just sort of saying how we are in terms of preparation for the new discharge guidance and talking us through that briefly. So I'll just give them a fair warning of that. On testing, yeah, it's a mixed picture, Ron, in terms of the weekly testing of all care home members of staff, really to spot the issue of asymptomatic presentation of COVID, which is a particular challenge. Some homes that's working really, really well. Others, they're having a delay in getting the test results. That's improved quite significantly recently. It's still not where it needs to be. The government have acknowledged that. They acknowledged that yesterday. I know Councillor Roberts has been keen that is addressed, and I think he's written with our guidance to the Department of Health and Social Care to make clear that his view around the importance of that. So it's a mixed picture. A number of homes report to me that's working very well. Others, it's not as reliable as it should be. It's vital that testing is as robust as possible, both in terms of the results, but also the timeliness of the results. It's that's key to the success. Yeah, on comparison around the deaths, that's actually something we've all learned about how those things are recorded. We will undertake some historical comparisons around mortality in the residential nursing sector and in home care. We'll do that to look at what the impact's been within Hertfordshire over time. I suspect the wider measure we'll want to look at when the dust has settled a little bit more is around excess mortality overall, which seems to be the measure that will pick up most things, and that we can look at that across time. I know Jim McManus and colleagues are doing a lot of work on that analysis, and that'll be forthcoming when they've got more work on it. But I think it's a point well made, Ron, that we need to look at the historical picture too, and also, of course, mortality often then drops right down later on after an initial peak, and that you see, and we've seen certainly over the last few months, fewer people passing away than we would expect in similar months because of the spike that we saw previously in April in particular. I thought I'd just bring Andy and Heidi in here to talk about the discharge guidance and the work that's taking place to put measures in place.
Shall I? Yeah, can we bring in Heidi first and then Andy? Thank you.
Yeah, so from a discharge guidance point of view, Andy and I are working across Hertfordshire to make sure that we're doing a county-wide approach. There are still some clarity that we need regarding the discharge guidance, as I'm sure, like the previous guidance, there is different interpretation of that. So we're still working with NHSE and I to get some guidance about the interpretation. Obviously, we've got to work a bit quicker with this discharge guidance because it launched on the 1st of September, and that's when we know the 6 weeks started. So we're already, 9 days into this process. So we're trying to get that information as quick as possible. We're having numerous meetings about all aspects of it and working with our partners at the moment. So I think from an ACS point of view, we feel like we're in a pretty good position in terms of understanding our processes. I think both Andy and I are probably slightly different positions working with our main acute trust and how they're implementing the policy. A bit like last time, there are action cards that we all need to adhere to it. So at this point, we're working with them to make sure that the hospitals are geared up to work with the discharge policy. And certainly Andy and I are working with them to understand what the gaps are and what we need to be supporting them with. But certainly I think from an ACS point of view, once we've got that clarity on the interpretation of the guidance, I think we're in a pretty good position to be able to deliver on it.
Cheers. Thanks, Heidi.
If there's any specific questions, please ask.
Have you got anything to add?
I wrote down 3 points really that I was going to make. I think Heidi's probably covered the majority of those off. I can hit on those if you'd like me to, or you may want to take other questions.
That's fine. Let's do this. Those are key points. Go for it.
I'll keep it fairly sweet. I think in terms of the latest set of guidance, it just confirms that we need to work through a discharge to assess model of care, which means accepting a level of trusted assessment to access social care services. I do believe that we've got work in place in terms of developing those processes, developing the practice around that, ensuring that we're compliant with legal frameworks. And so that's all in play. We're also looking at our staff and resources as well, because the model calls for us to move some of our staff away from hospital sites to be able to assess within the community. So we've got a lot of that in train. I would say the other point is about readiness for winter and potential second surge. So again, we've got joint commissioning plans, and one of the opportunities COVID did give us was to work more collaboratively with CCG colleagues in terms of establishing joint resources. So part of our challenge probably comes then onto the third point, which Heidi alluded to, was about how we support people transitioning off resources that were accessed during Scheme 1, which was the funding arrangements that were in place up until the 31st of August, which would free up capacity within both bed and home care resources for later on in the year, and then how we work through the challenges of Scheme 2. As Heidi said, those conversations are well developed, I think, across the county, but also in our individual systems as well.
Thank you for that, and can I thank Heidi and Andy particularly for all the sterling work they're doing. I've been involved with Andy a couple of times at Watford Hospital, and I've always been very grateful. Can I just say at the end that the one issue that I think all councillors are getting is the occasional relative who is contacting us because of access to their loved ones in care homes, and also the effect on the individual residents if they're suffering for dementia or they've got other problems and they're not seeing their loved ones, and that can get them into a situation that deteriorates. So for me, testing is the regime. If we haven't got that testing in, then the local lockdowns will have to continue, and that is going to cause more distress. So for me, testing is the real key to all of this, and the government has just got to get it right for a change. Thank you.
Thank you, Ron. Yep. And Chris, you wanted to come back?
Yeah, I mean, Ron, you're absolutely right about the centrality of testing. The issue around care home guidance, care home visiting is a really difficult one, a balance between protecting those from the virus, particularly around asymptomatic transmission, which we think is the really difficult one to manage, but also people's well-being. I'm sure a number of people, including myself, have had personal experience of the challenges that brings. You know, we've got to be honest. We will have to reflect with colleagues in public health and across the system on care home visiting, as and when the outbreak levels go either up or down, and we'll have to make potentially difficult decisions about care home visiting in the future based on the level of risk and the level of COVID being transmitted in the community. They're difficult decisions to make. There's clearly a massive balance between infection control and people's overall well-being, but we've got triggers that we will enact when that happens, and we'll look wherever we can to maximise the well-being of our care home residents, but being very clear that we've also got responsibility around infection control.
Thank you very much.
Thank you very much. Thank you all. That is one of the it's about to become, I would imagine, in the very near future, ever more challenging, and that is something that we, the care home providers, we're going to have to work our way through. It's probably one of the, as you said, Chris, exposing cruelly, I think really is that isolation that comes about because we're trying to protect is really a difficult one. Right, Nigel Bell, if you could come in, please.
Yeah, thank you, Chair. And Ron, fair enough, has already raised, and they've been answered questions about the death rates and the comparisons and test and trace. But can I then just obviously Chris had mentioned about 5-9 about obviously Nevetts in Buntingford and the Fairway in South Oxley, and I gather, and they're obviously going to be still going to be kept open as a pathway out of future COVID. So just wondered if you can comment more on that. I was pleased to see that the hub was put forward, and I think has been recognised for best practice and all the things that have come out from that. So that's good. That's very good to see. And obviously looking at the additional costs, the PPE obviously is the main thing again with the 4 million. But I just wondered if that had changed, or if if that the way we have to finance since sort of PPE, if that has changed because of what we originally found when when we first had to pay for the PPE. Thanks.
Okay, so yeah, on Fairway and Nevetts, obviously great work from the teams to get those units back up and running. We will be keeping those open certainly until I think we've got agreement to keep those open till at least April. And again, I'd rather they were there and empty, but there to be used than being used in a sense, because that would show that we've got a wider issue. But in a sense, as an insurance and part of our winter planning, we will keep those units operational. PPE changed. The dynamic on PPE was one that where there was acute shortages, we were paying a much higher price. It was clearly a very challenged market to secure PPE. That has become easier as supply chains have eased. I think that 4 million equates to the amount we've paid for some of the stuff in-house. We've also the amount of money going to providers, which we'll talk about in the next round, has been significant in terms of PPE. We've been supporting providers in that. We felt that's a priority. I think it's fair to say that there is a consensus that there will need to be a national solution to both the ongoing supply of PPE and the funding for it, because clearly it places a significant burden on social care providers to secure provision of PPE, which is important, and that's not built into the costings that certainly we apply to them. So that money is going to need to come from somewhere, and I know conversations in government are live on that as we speak.
Thank you.
Thank you, Nigel. Just coming back to Fairway and Nevetts and PPE in a sense, this preparedness that we now have, it is awful that we've had to go through a phase one in a sense, but the learning is there in place. So Fairway and Nevetts are now in place. So whatever happens as this infection rate is increasing, we have got facilities and understanding, learning, which we can constantly review, but that's in place now. And that's the PPE. That dynamic is really, really helpful. Thank you, Chris, and to all the teams for being part of that. And to Sue Darker, who I believe ex-AD of this organisation, now back in helping to support in that area. Excellent. I've got Nigel Quinton to come in. Thank you.
Yes, thank you, Chair. First of all, big thanks to everybody who's put stuff together in very extreme circumstances. I think there's some really good practice that's come out of this, and hopefully the better working between the NHS and ACS is going to continue. The question I had is, it's a bit about the money and where we're at, and I must admit I'm totally confused. I'm sorry, I'm sure many people are, as to the nature of the changes on the 31st of August going into September. What the NHS, I think, comes up on our item 6 as well. I think where the division is between who pays for what and what the implications are for your team, Chris. I just wonder if a very short summary of that situation, it may be in the papers, I couldn't find it in a way that I understood, but if someone could write down just a summary of what has changed and what the implications are, I think that would be helpful for all of us.
Yeah, can I suggest that we pick up the broader point in the next item?
Yeah.
We'll do all the finance stuff in the next item. And Nigel, the question you ask is absolutely right. It is so much changes so quickly, and that's before anybody's responded to it and then had to ameliorate it as well at a local level. So I think you're absolutely right to seek that understanding, and Crystal team can put something out. But the point about let's discuss it in the next item, all the
Yeah,
financial
if I may just come back on one thing. I mean, I noticed we've got an item on 6.12. It talks about the government funding and the Infection Control Fund. Now, we also had an email that came out to our group via the resources team from Scott, I imagine, or somebody in that department, which listed that fund as an additional burden on the county, which didn't seem to make any sense at all to me, because it's more money. So yeah, the whole subject of the financial implications on this, I think, is just very confused. Anyway, I'll leave it there.
So there we are. We've got a way forward there. That's great. Thank you for raising that, Nigel. We'll pick it up in the next item. You're not being ignored. Drida, did you want to come in?
Thank you, Chair. Thank you. Yes. Yeah, I mean, most of the points that I wanted to raise have already been covered, so I won't go over them again. The issue that I did want to raise with Chris is in terms of equality implications, and I wonder if we have any data on the impact of COVID on the travelling community within Hertfordshire, because as you'll be aware, their health outcomes are generally poorer and their life expectancy is lower than that of the rest of the population. Thank you.
Thanks, Rita. Sorry, thanks, Rita. Yeah, I mean, we've got, we obviously know that, nationally there's been a lot of coverage of the again, kind of cruelly exposes existing inequalities as a disease, and we've seen the different impacts it has on people, sometimes because of, it's difficult to disentangle that. Is that because of the genetic factors? Is it around deprivation and how that intersects with, for example, race and age and so forth? So we're trying to look at our own data on that to see what we've got around, for example, traveller groups and ethnicity and race. We're in the middle of that work at the minute. I haven't got anything I can share immediately with you and give you a direct answer on that, but I'll go away and have a look to see where we've got to with that work, and if we've got any early findings, share that.
There we are. Thank you, Drida, for that question. Just to echo what Chris has just said, and I suppose, again, the understanding of the physiognomy of this particular disease, and it's not just a lung disease, but it's a blood disease, is really important as well. And it's so what keeps coming through time and again is your general health is so important, and those with underlying health conditions are a little bit more vulnerable. And we know that BAME community have a slightly higher preponderance to suffering from COVID-19 symptoms. So be careful, keep washing your hands, keep using the masks, social isolate. Those messages need to get through really loud and clear, and particularly at the moment where we know the infection rates have increased. I'm sorry if that sounded like a public broadcast. It was really, but it's so important just at the moment. Thank you. Are there any further questions? I don't think there are at the moment. That's fine. So that's fine that Drida has come in before. Panel, I think it'd be really helpful if we could, if I could ask you to note our debate and our actions from that, some of which are going to go straight through into the next agenda item, but just to note and our comments on this report and whether you agree to accept this report. Thank you. Yeah, that's lovely. That's coming through loud and clear. Thank you very much. Can I just say, Chris, to you and your team, you have been in emergency mode since February, and I am very aware that daily you are dealing with COVID as well as trying to run a £500 million adult social care department and its relationship with health. I can only, on behalf of panel, which has already been said, thank you for the work that you have been doing and will have to continue to do with quite an impact on sometimes on the social well-being of those staff working long hours and doing a lot of screen work. I'm really, really grateful for that. And I know panel are as well. So thank you very much.
Could I just extend that to from on the department's behalf, and I'm sure everyone else's, the thanks to those working in the wider care sector, care homes, domiciliary care, not often get the prominence of recognition that those in other sectors do, but actually have worked under the most extraordinarily difficult circumstances, often facing trauma around what they've experienced, but the resilience that they've shown has been unbelievable, really. And I think if anything good comes out of this, should be a recognition of the value that social care has in society, and the work we've had from providers and support in Hertfordshire has been really great and couldn't have been better.
I think Chris, what I would just reflect to build on that as well is a lot of those staff, whether it's domiciliary care or work in a care home or nursing home, are wearing PPE for all of their shift. That is hard work, and we should just commend people for just that extra endurance in a sense. But also to reflect that infection rates since the peak have been so much lower as infection control measures have been kept in place, put in place by the providers and by the diligence of staff. And particularly, we've had very little infection in domiciliary care as well as in care homes. So I couldn't agree more. Thank you for raising that, and I thank you for that sentiment. Good. So that takes us to our really quite neatly into our final item, which is what is our support for care providers leading up to Christmas, and just laying out the financial position, considering that through to March as well. Jackie, you're coming in to present this to us. The paper is well written and quite clear, but just, I think, reflect on Nigel Quinton's points around clarity about exactly where that spend is, and some of the difficulties in separating that out. May not want to do all of that now, but just recognising Nigel's points being a perfectly valid one. Thank you.
Perfect. Well, I'll assume that that you've all read the paper, and I'll just give you a brief summary of what it's asking. So as Chris said in his report, that we've had support in for care providers since March, and we've been supporting them in two ways, with additional costs of their PPE and their additional staffing, their staffing costs, and also been supporting them with under occupancy by guaranteeing the level of payments that we make, and that is due to end at the end of September currently. And we've, as Chris said, we've had a lot of positive feedback from providers about them feeling very supported in that financially. The paper recommends extending that additional support for their additional costs to the end of September, so that to the end of December, sorry. So that's the cost of their PPE and staffing, and suggests stopping the guaranteed payments for under occupancy and dealing with that in a more targeted way to support those providers that may be specifically experiencing short-term financial difficulties. The proposal is that this is funded through the ACS base budget, which has an underspend at the moment, and also highlights that it is likely that we would need to extend that to March and potentially beyond. The proposal does assume that we don't get any additional funding from government to support this. In terms of Nigel's point that you asked me to comment on, I think it would be helpful if I do that as a note that comes to members after that, in terms of summarising the overall position, because I know there are loads of different funding streams that we've had, a number of grants that we've had in that we're using for different things, including the Infection Control Fund, and I think it has got. I think it'd be helpful if I just pull together a note and share that round to as a summary. With that.
Thank you, Jackie. That makes perfect sense. Yeah, that's great. Thank you.
And that's really it. That's in terms of the paper. If anyone's got questions.
Yeah, I'm sure there are questions. Jackie, grateful. I think this is cutting to the chase with this paper. This is almost common sense. We have asked our providers to look after our most vulnerable residents, And this is how we can help them to continue to do that up to Christmas and potentially through to March. And very obviously, we may well have to do this beyond that if we haven't got vaccines and all the rest of it. So, colleagues, I'm very happy to take questions. And I think, Nigel, do you want to come in first?
Thanks, Chair. Yeah, and thank you, Jackie. That's very helpful. I think that would be very helpful indeed. The a couple of other questions on the paper. Under recommendation 1 or 5.6.2, it says that the deadline for applications from providers for costs incurred July 2020 is 31st of August. That strikes me as quite a tight time frame for an organisation to identify all the costs up to the end of July. It's basically 1 month, and I know, particularly through difficult periods, that might be a challenge. If you could offer any reassurance on that, that would be helpful. And the other question was just to highlight the main thing I was confused about was in in section 6 really, and the conclusion in 6.6 that there is a reduced funding offer from the NHS to the care market from the beginning of this month. And I just like, that was the thing I'd like to see clarified as to how much that is. And I don't understand, I'm not. Is that, I mean, I assume that's something that's been set by central government. It doesn't feel right that that burden does come back onto us. But whether there's anything we can do about that by lobbying, I don't know.
I think that is worth exploring, Nigel. Just to is it an extra burden on us, or is government giving us money to pay for that anyway? Exactly. Let's just explore that, because I think that kind of goes to the heart of the financing, really.
Yeah.
Right. Yeah. So what's been happening, the sort of what we call the block surge beds that we've been holding and with providers to cover the discharge from hospitals, we've been funding that with providers. So they've been getting block bed payments to hold a number of beds for us to be able to make sure that throughput and discharge is effective from hospitals. And we've been claiming that we've been the lead commissioner for it, but we've been claiming that from a health grant. So the health fund, the CCGs have got funding for those additional costs, and we've been claiming that through them. And what happens is that sort of funding is beginning to come to an end. Or there are arrangements for the various bits. The arrangements we've got in place continue. It's really, there's a change from the 1st of September ongoing, so that those costs, and that's what we're trying to work through at the moment in terms of the changes, which is what I'll reflect in the note once we've worked that through. But in terms of that bit of that funding is we've had some money that we've been paying to providers for block beds to respond to that discharge request, and that is beginning to come to an end now.
There we are. And Jackie, just to be clear, that funding was effectively the 1.3 billion that was given to the NHS for exactly that purpose, wasn't it?
Yes, it's for that and some of our ongoing care to speed up discharge out of hospitals. We've been putting in care packages, and some of those have been claimed against the NHS as well.
There we are. That's really helpful. Thank you. Nigel Quinton, did you want to come back? Are you covered there for the moment?
I'm happy with that, Richard.
Yes, thank you. Lovely, thank you. Nigel Bell.
Thank you, Chair. I just wanted to check, maybe it's more for Chris, I don't know, that obviously we were going to get all the extra funding, but that obviously on the under occupancy, we wouldn't obviously going to fund that. But if we do get more extra money that we want, and even more over and above, we may not, how will that affect the what is the implications going to be for that under occupancy not being funded?
So to clarify, we can still fund under occupancy if we get a measured case from a provider where they're really struggling for sustainability. That will be dependent on, I think we've laid out the factors in there, the quality of that provision. What we couldn't afford to do simply is underwrite that for the whole sector, because that would have been really, really difficult. But where we get an individual request, we've lined up a process by which we can make those decisions. Number one being, have we got any spare funding to be able to do that in the care purchasing budget? Number two, is that capacity that we like, is it of a good quality, and is there a plan for that provider to get back to financial sustainability? So we think we've got enough coverage to be able to provide the support in a targeted way. I suppose if we get funding for things like PPE from government or more infection control monies, we've agreed that that clearly would go to providers. That would then replace the support that we're providing and would reduce the financial burden on us as a council, which we would then clearly be able to use for different purposes. There remained a number of financial challenges across the council that need to be met as a result of COVID. So we would, and again, anything that we can get from government that reduces that burden, reduces the likelihood of us having to use monies or reserves or whatever the alternatives would be. So when we see what that grant looks like, we'll be able to make those decisions. Clearly, we won't be giving providers double the money that they would normally get. We'd be securing the promises that we've been made. We'd use different money to do that, and there's no shortage of demand for resource to support the council's COVID response, and we'd have to make a corporate decision about how any extra surplus monies were used.
Okay, thank you.
Great. I don't see any further questions coming through. So one, obviously, Jackie, the report is itself clear, and your presentation of it is perfectly acceptable to members. That's good. I think the key point is that any ongoing clarity, I suspect, is what we're talking about, as alluding to what Chris has just talked about. The sums of money involved to maintain the support for providers will exceed this council's budget at some point in the future, unless government steps in or we put council tax up by an amount that's never been put up before. So sorry, it would be a very large amount. So I do anticipate some further support, and I can't see that the government would in a sense would step away from that responsibility. It's because it's very writ large across the country. Jackie, thank you so much for this. My own view is, I said it before, we have supported the providers from before COVID actually hit Hertfordshire. We negotiated with them, we set up support, we worked with HCPA, we set up the provider hub. We will continue to do that. This is another extension of our support for the care provider market. It is essential for our most vulnerable residents, and long may this continue until there is some further control on COVID, which at the moment there isn't. So the recommendations under 3.1, I'll tell you what I'll do. I'll just read them out. Apologies, it's a bit tedious, but I'm just going to read both the recommendations out. Support further financial provision for all commissioned care providers to meet the ongoing additional costs of COVID-19, PPE, staffing, etc., but not under occupancy until the end of December 2020. That is recommendation 1, and review current care market risks and set of principles for supporting care providers at risk of failure arising from under occupancy by introducing a process, as described just now, through which county council commissioned providers at risk of failure be offered short-term funding to support resilience on an open book basis, entirely transparent basis, and that's recommendation 2. So panel, I'm asking or recommending that we support those recommendations to support the provider market in the way set out. There we are. Okay, I'm just ever so slightly remiss. 3.2 of the recommendation is panel is asked to recommend to Cabinet that it notes and authorise the interim director of adult care services to fund this support from adult care services, and then a detail below under recommendations 2 and 3. So that was made clear in the presentation. I tell you what, let's just go through that one more time. Are you comfortable with the full recommendation as a 3-1 and 3-2? So let's just go through that again. My apologies. There we are. So thank you, Stephanie, for formally bringing that up in the chat. I'm just letting public know that is a universal support across all the parties for this provider support up until Christmas, setting out the criteria by which it will be given and delivered. Thank you, panel, so much for that. That brings us to the end of our formal business. I'll just check if there's anything else I'm supposed to do. I'm sure it'll pop up in chat if there is anything I'm supposed to do, but I don't think there is. Thank you all very much. A huge contribution by everyone. Dave, get better soon. And to the support that's come in from officers this morning, thank you very much indeed. Now can you get back to your day jobs and stop messing around? Okay, thank you all very, very much indeed.
Thank you, Richard. Well done.
Yeah, thank you, Richard.